We are online now.
Good evening, delegates and participants. Thank you for joining Shield Connect. And today's webinar is been sponsored by Society for Maternal Fetal Medicine India. And today we are back with the series, virtual learning series on Pre-Eclampsia 2022-23, part 2, the education for the empowerment. And before we start with the session, let me introduce our coordinator, Dr. Anju Joseph. So, ma'am is currently consultant and medical director of Trinity Healthcare Clinic in Electronic City, obstetrician and gynecologist, fetal medicine consultant in Kaveri Hospital, Ma Kaveri Unit in Electronic City, Bangalore, and visiting consultant in fetal medicine in Aspire Fertility Center, Motherhood Hospital, and Narayan Multi-Speciality Hospital. And the area of interest is first trimester aneuploidy screening and prevention in high-risk pregnancy. Ma'am has been awarded and and has a recognition from EC member of SMFM and event coordinator of the VLSP. So I welcome you, ma'am, on our platform, and I will hand over the session to you, ma'am.
Thank you so much. Thank you so much for introducing me. Welcome one and all. I do work as a event coordinator for this virtual learning series. Sahiti, if you could put up the CV slides. So my job for today is to introduce all our eminent members on the dais. To start with, let me introduce you to our old mentor. All of us have been probably, a good number of us have been mentored under Dr. Prakash Mehta. Sir is the Chief Division of Maternal Fetal Medicine, Head of Department of OBG from BMJ, Mahavir Jain Hospital, Bangalore. Sir is our President to the Society of Maternal Fetal Medicine, India. Sir is also the co-chair for the PENAI program, which you'll be hearing about in a while. His main area of interest, whatever he says maybe, is teaching. And second comes, I would say, as high-risk pregnancy. He's been awarded as a best teacher in multiple platforms, and he has received his Lifetime Achievement Award from the BSOG. Sir has not joined us yet. He is out of station in Vancouver. We're trying to connect to him. We hope he joins us in soon. In his absence, so welcome to you. Dr. Saroj Rana has been our guiding light to know where to go to, how to go about with things, and has been of immense help to make us understand how to go about in a larger platform, go internationally, spread the word, the importance of pre-eclampsia and things like that. Madam is presently the Section Chief, Maternal Fetal Medicine and Professor of OBG in the University of Chicago, USA. Madam is the co-chair of the Global Health Committee at ISSP and international advisor for our own society, Society of Maternal Fetal Medicine, India. Ma'am's area's interest is pre-eclampsia research and the clinical application of androgenic biomarkers in pregnancy and postpartum. She's been awarded a MD Mentor Award for sustained excellence in mentoring and Castle Connolly's Exceptional Women in Medicine Award in 2020 and Top Doctors Award also in 2020. Welcome, Madam.
Yes,
Next
thank
slide,
you.
please.
Welcome, everyone.
Hi, ma'am. Hi, ma'am. Happy to have you here. Next on the list of our faculty for today is Dr. Revati Rajan. Dr. Revati has done her fellowship in fetal maternal medicine, and I'm proud to have her as my senior. Currently, she is the chief consultant of maternal fetal medicine and managing director of Mirror Health, which is in Bangalore. And she is also a visiting consultant at Millen, BMJ, TCH, and NMC Bangalore. She's a secretary for our society and the co-chair, Indian co-chair for PENI program. Her areas of interest is hypertensive disorders in pregnancy and with particular interest in pre-eclampsia and in utero programming. She has been awarded multiple awards from FOXY, especially with the UA FOXY Kamini Rao Orator Award and the All-Rounder 2016 Award and Certificate of Excellence in all categories of research and young scientist at the second Academic Brand Awards, New Delhi. And she has also been awarded as the Incredible Researcher of India in 2021. Welcome, Dr. Revati.
Thank you so much, Chanu, for that warm introduction.
Dr. Smita, she's done her fellowship in fetal maternal medicine and at present works as fetal maternal medicine consultant in Cloud9 Hospital, Bangalore. She's the founder treasurer of Society of Maternal Medicine, India. Her area of interest is high-risk pregnancy. I'm proud to have presented her today as a wonderful colleague and a great friend of mine. Welcome, Smita. Dr. Manisha Kumar, Madam is the Director and Professor, Department of OBG, Lady Hardinge Medical College, New Delhi, and she's in charge of the fetal medicine and the genetic lab there. The research projects that she has undertaken are risk stratification in preeclampsia by the use of biomarkers, placental profile markers for adverse pregnancy outcome, birth defects and stillbirth network, screening and diagnosis of genetic diseases, and artificial intelligence application in hypertensive disorders of pregnancy. We welcome you, ma'am, and we hope we can hear a lot from you from the extensive areas of research that you've undertaken.
Thank you. Thank you so much for inviting me here.
Thank you, ma'am, for joining in. Next on dais is Dr. B. Nagaratnama. Madam is not a new face for us. Madam is known as Madam and also as our Shruti's mother. Madam is a professor and HOD of Department of OBG, Rajarajeshwari Medical College and Hospital, Bangalore. Ma'am is a chairperson of Female Breast Committee at Kasoga and the president was a president of BSOG in 2019 and 2020. At present, she's an executive member of KSA and also has conducted several CMEs, workshops, conferences, and chaired many sessions and given guest lectures at the state, national, and international conferences. She's had various publications and chapters for FOXY and for BSOG. RGH's ongoing clinical trial on predictors by pre-eclampsia by androgenic markers is being undertaken by her, and the special area of interest is urogynecological procedures, high-risk pregnancy, infertility, and gynecology. Welcome to you, ma'am. Dr. Srimati Ramanan, Madam is the consultant OBG and high-risk pregnancy at Rangadurai Medical College Hospital, Bangalore. Ma'am's areas of interest are maternal medicine and high-risk pregnancy, advanced labor management, labor ward management, clinical governance guidelines and protocol development, teaching and training. Madam is an MRCOG examiner and is also a reviewer for the Green Journal, which is the official publication of American College of OBG. She's a DNB trainer and also a trainer for RGH's fellowship programs. She has been awarded 10 gold medals, 13 prizes and medals during her MBBS college and university level. As you know, she is a great academician and every time it's a pleasure to have you, ma'am, as one of our panelists. Welcome to you, ma'am.
Thank you, Dr. Anu.
Dr. N. Saravanakumar, sir, is professor in HOD Department of OBG of Annapurna Medical College. He's done his MBBS from WIMS Bellary and MD from MMC Chennai. He is presently the Secretary of Obstetrics and Gynecology Society of Salem and also the organizing secretary of FOXY South Zone Conference with UVA 2022. He also concurrently works as consultant in Malla Maternity Hospital and has initiated and trained young gynecologists to operate laparoscopy in Annapurna Medical College. His field of interest is high-risk obstetrics and gynecological endoscopy. Welcome to you, sir.
Thank you, ma'am.
Our own Dr. Chaitra. Doctor is a fellow in maternal fetal medicine from Milan. Presently is working as consultant at FMF at Milan. She has gained her experience in high-risk obstetrics at Vanivilas Hospital and has been keenly interested in medical disorders of pregnancy and critical care in obstetrics. At present, she is an EC member for SFMI. Welcome, Dr. Chaitra. Dr. Sunita, she is presently the medical director and senior consultant of maternal fetal medicine unit in Bangalore. Areas of high interest are high-risk ART pregnancy and management of recurrent pregnancy loss. She has been the executive committee member for BSOG, executive committee member for SFMI, and the chapter formulation coordinator for SFMI. Welcome, madam.
Thank you, Dr. Anu.
Hi, ma'am. Sahiti?
Yes, ma'am.
Yes. So you can go back to the SFMI slide.
Okay.
Sir has joined in.
No, Anu, we're not able to reach out to him. Maybe there are some network issues. You could just welcome everyone on behalf of the society.
This is something unprecedented for us that sir has not been out of reach. Every time that we've had an issue, we have had a question, we have had anything to discuss, we have had a program. So would be the first one who would be there joining in. And today, I wish he was here, but then he is out of India and probably he's having some network issues. On behalf of sir, I would like to extend my warm welcome to all the panelists, all the invited speakers, Dr. Sarosh Rana, Dr. Nagaratna, Dr. Manisha, Dr. Saravanan, Dr. Srimati, all the panelists, all panelists from SFMI, invited delegates, the delegates who have joined in from as far as Bangladesh, all the team from SHIELD, the team from SFMI, who in spite of being a Sunday is working with us to make this a smooth going process. All the delegates who have joined in as a member of the PENAI program, which is going on. I invite you all to this program. I hope we all learn together and we have a wonderful experience from today's academic talks. With that, I hand over the stage to Dr. Sarosh Rana for addressing the gathering today.
So thank you very much. Yeah, I'm kind of very surprised that Dr. Mehra is not joining, but I know he always joins all the meetings. It's really late at night here, so maybe he's in the same time zone. But regardless, so welcome everyone. It is my pleasure to be here, and I try to stay for as long as I can. I just obviously wanted to say what a great initiative you guys are doing to educate everybody, and I will for sure say that use of androgenic biomarkers, I'm really hopeful that people will learn from this session, and definitely it's available in India to see how we can actually use this in clinical practice. And I know that Revati has been using it in several other people. So I think that will be, I'm really hoping it will be very fruitful discussion for all the cases that, you guys have prepared so diligently. So welcome everyone. I also wanted to say a couple of words about our PENAI project. So that's our flagship educational program. And I would highly recommend you spend a lot of time, Revati spent a lot of effort in creating those modules. It's very user-friendly. I would say it's highly educational. So I'm really hoping that people will really use more and more of it and join it. And then spread the education. I think it's obviously lots of people have put in a lot of effort in it. So I think personally, I feel we've been having these sessions and all we have is really positive feedback. So I will highly recommend that you should check out that project. And lastly, I would say that we are very happy and excited that the ISHIP, which is the International Society for the Study of Hypertension in Pregnancy meeting in 2023 is being held in Bangalore. So that is so exciting. And Dr. Rajan and Dr. Mehra, and they've been trying, they've been kind of taking the lead on that. So I'm super excited to just come there and meet everyone in person. I won't take too much of your time. I know Revati has a long agenda. So I'm here and I will try to stay awake. It's really late, but we will hopefully have really good sessions. So welcome everyone.
Anu?
Thank you so much, ma'am, for that. I now invite Dr. Smita, who would be joining us with a sound bite, which is on screening for preeclampsia. Dr. Chitrakala, Mr. Chitrakala, if you could on the recording.
Good morning, everybody. This is Dr. Smita, and today I'll be discussing with you all about the screening for preeclampsia. Why do we need screening for preeclampsia? We all know that preeclampsia is a multi-system disorder with its origins early in pregnancy, and the pathophysiology is a complex interplay of maternal, fetal, and placental factors. The incidence is quite high in India compared to the rest of the world, and we are at 8 to 10%. It is second most leading cause of maternal mortality worldwide. And what makes things worse is the atypical presentations, which cause clinical dilemma for diagnosis. Definition of preeclampsia has transitioned over the years, and the latest one being by the ISSHP 2021. Preeclampsia de novo, what is it? Preeclampsia de novo is gestational hypertension with one or more of the following new onset conditions at or about 20 weeks. So this is proteinuria, maternal end organ dysfunction, which can include neurological complications, pulmonary edema, hematological complications, acute kidney injury, liver involvement. And last but not the least are the uteroplacental dysfunctions, which can vary from an abruption to fetal growth restriction to abnormal Doppler indices, and lastly, intrauterine demise. Preeclampsia is superimposed on chronic hypertension. This occurs more commonly in women with chronic hypertension who develop new onset proteinuria along with other evidence of maternal end organ dysfunction and with or without uteroplacental dysfunction. However, the more conventional classification that we are all familiar with is the early onset and the late onset preeclampsia. So we all know that early onset preeclampsia has more adverse perinatal and maternal outcomes, whereas the late onset has more favorable outcomes. What is the root cause and consequence of preeclampsia? The root cause, as we all know, is maldevelopment of placental vasculature, which causes placental perfusion insufficiency, as well as hypoxia, which terminally cause endothelial damage and hypertension. The maternal adverse effects are the most familiar and striking, with eclampsia, abruption, stroke, and multi-organ dysfunction. The perinatal adverse effects range from growth restriction, low birth weight, to stillbirth, intrauterine demise, as well as iatrogenic preterm births. What is the rationale for screening, and is there any evidence? Screening not only allows early detection and planning, but also favors early incorporation of appropriate interventions. So as per the US Preventive Task Force, adequate evidence has been found in screening for preeclampsia, which is beneficial both to the mother and the newborn. So this is based on the results of MAGPIE and HEPATAT trials. What are the methods available for preeclampsia screening, as well as what is the basis of it? We all know that preeclampsia is heterogeneous in terms of causation and presentation. So this is reflected better with 2 or more biomarkers associated with pathophysiological process, along with patient characteristics, which forms the crux. So screening strategies include clinical history and maternal characteristics, which are the basis of any screening procedure, clubbed with uterine artery Dopplers, biomarkers, which include PAPA and PLGF. The others definitely include a lot more, like leptin, selectin, inhibin A, activin A, urinary albumin, or calcium. The genetic basis of preeclampsia has long been debated with a polygenic inheritance, and the meta-analysis has also shown that a higher risk of preeclampsia with coagulation factor 5 gene in women. Coming to the foxygestosis, ICOG, hypertensive disorders in pregnancy, good practice recommendations. Prediction of preeclampsia. Universal screening is recommended, but there's no single screening test. None of the tests proposed to screen the high-risk population can be recommended for the general population. So what is very important is the clinical assessment of risk factors, which is the basis of any screening procedure. So this needs to be done in the first trimester and can be easily done by any healthcare worker using the HDP gestosis score. What is the hypertensive disorder in pregnancy gestosis score? It's a very easy to use score wherein several criteria are given scores of 1, 2, and 3. And whenever the score is equal to or more than 3, the woman should be marked at risk for preeclampsia. These are the risk factors which are given a score of 1, which include age less than 19 years or more than 35, maternal anemia, BMI more than 30, primary gravida, short duration of sperm exposure, women born themselves as small for gestational age, family history of cardiovascular disease, polycystic ovarian disease, interpregnancy interval more than 7 years, conceived with ART, especially the IVF-HC conception, mean arterial pressures more than 85 millimeter of mercury, chronic vascular disease like dyslipidemia, excessive weight gain during pregnancy. So what scores are given for a score of 2 and above are maternal hypothyroidism, family history of preeclampsia, gestational diabetes, obesity with BMI of more than 35, multifetal pregnancies, hypertensive disease during previous pregnancy. The highest score of 3 is given for the following, which include gestational diabetes, chronic hypertension, mental disorders in women, inherited or acquired thrombophobia, maternal chronic kidney disease, autoimmune diseases like SLE, applied rheumatoid arthritis, and pregnancy with assisted reproduction, especially with oocyte donors as well as surrogacy. What does the FIGO recommend for screening for preeclampsia? All pregnant women should be screened for preterm preeclampsia during early pregnancy by the first trimester combined test with maternal risk factors and biomarkers as a one-step procedure. Coming to the combined test for preeclampsia, a combination of clinical factors and biomarkers, which include maternal risk factors, the MAP, PLGF, and uterine artery PI. This is an example of the first trimester risk assessment for preeclampsia, which has been devised by the Fetal Medicine Foundation. So this not only integrates the history-based medical history as well as the obstetric history, but also the maternal characteristics as well as the sonological characteristics with the biochemical markers as well. So what do we do when we don't have access to PLGF and uterine artery PI? So not to worry, we still continue with maternal risk factor assessment as well as MAP. Efficiency would not be as great as it would have been with the biomarkers and with PLGF. So we could also follow a contingent screening in limited resource setting where we use maternal factors and MAP as the first line to detect at-risk women and then subject the high-risk women into further testing with biomarkers as well as uterine artery PI. So the key points of FIGO recommendations and how do we measure the mean arterial pressure? Blood pressure measurement is a day-to-day thing and we all tend to ignore it. So what we need to keep in mind is needs to be done with the woman in the sitting position with arms at the heart level, usually with the right sized cuff and after 5-minute rest. So the BP needs to be measured in both arms simultaneously with 2 sets of BP measurements at 1 minute interval. So totally we have 4 readings and an average of which has to be taken using the calculator. So how do we interfere with women who have been found to be at high risk for preeclampsia? We need to start them on aspirin with dosages of 150 milligrams, starting as early as 11 to 14 weeks and continuing up to 36 weeks. And not to give a low dose aspirin for all pregnant women universally. Coming to the calcium intake, it has been long implemented, long indicated that low calcium levels can predispose the risk for preeclampsia. And the calcium supplementation of 1.5 to 2 grams needs to be considered in women with low calcium intake. Multiple pregnancies, do we test them or how do we go about testing them? The combined algorithm can be used for multiple gestations. Though there is high detection, we also see that there is a high screen positive rate. So what does the ACOG and SMFMI say about preeclampsia screening? They support the US Preventive Task Force guidelines on the use of low-dose aspirin to prevent preeclampsia. offer low-dose aspirin in addition to women with more than one risk factor for preeclampsia. According to ACOG and SMFMI, only
ಹೌದು ಕರ್ದೆ ನಾನು ಅದಕ್ಕೆ
some medical history along with the uterine artery Doppler ultrasound and biochemical markers are not given more significance compared to the maternal history and MAP. This is because there is lack of large prospective cohorts which have been studied, and until the larger studies are incorporated, it is not substantial to conclude the use of biomarkers and the uterine artery PI in screening for universal screening for preeclampsia. So this is a flow chart which has been devised by ACOG and NICE. So basically, the maternal characteristics and clinical history are the background. In addition, if any of the major factors are present, like hypertensive disease in previous pregnancy, chronic kidney disease, autoimmune disease, diabetes, chronic hypertension, multifetal gestation, the woman is deemed as screen positive, or with 2 or more moderate factors like first pregnancy below 19 years of age or more than 40 years, inter-pregnancy interval more than 5 years, BMI more than 35, family history of preeclampsia, IVF pregnancy, and primary paternity. Then also the woman is deemed as screen positive. Once the woman is deemed as screen positive, what we need to offer is the biomarkers and the integrated risk assessment with the ultrasound markers as well. So what needs to be done, like we discussed earlier, women need to be supplemented with high dose calcium of 1.5 to 2 grams per day, especially if their intake is low, less than 800 mg per day. And women also need to be treated with aspirin, not at 75 milligrams, but at 150 milligrams per day. This is again backed by the proof that platelet insensitivity to aspirin is seen in as high as 40% of the women, especially the ones with a higher BMI. So a dose of 150 mg per day is justified as per the ASPER trial with ongoing monitoring and surveillance for preeclampsia. Again, we spoke in detail about the blood pressure measurement. So what we need to talk is about proteinuria. Proteinuria should be more than 30 milligram per millimole, and as well as the albumin creatinine ratio, which can be more than 0.3 grams per day, or a dipstick of 2 plus or more. So this chart gives us a significance of combined screening in first trimester for preeclampsia. When you look at the MAP, uterine artery PI and PLGF, with a 5% false positive rate, there's a confidence interval of about 87%. The predictivity is much higher when compared to combined MAP, uterine artery PAP A and PLGF, which is much more higher at 93. So this goes in favor of early diagnosis of preeclampsia and the effectivity of these biomarkers, as well as the sonological markers in early gestation. What are the preventive strategies? We all know primary prevention is not a feasible option, which is avoiding pregnancy in women at high risk for preeclampsia. Secondary prevention is definitely in target population who are at high risk by administering aspirin as well as calcium. Tertiary prevention, again, is prevention of complications with the use of MagSelf to prevent eclampsia. Coming to cost effectiveness of screening in preeclampsia, are we being cost effective or are we being unreasonable using biomarkers? There has been a lot of evidence that there are huge cost savings, especially not only by averting eclampsia, but also by reducing the morbidity on the neonate and the reduction of preterm delivery. Let's conclude it with these following key points. Preeclampsia is complex and heterogeneous in nature with varied presentations. Prediction of preeclampsia is again based on multi-parametric approach. Maternal characteristics and clinical history are the mainstay in identifying women at high risk for preeclampsia. MAP and uterine artery PI for screening would be optimizing the performance. Screening for preeclampsia combining maternal characteristics, clinical history, and biomarkers along with MAP and Doppler mean PI are more effective, but they're limited by cost constraints in low-income groups. Hence, can be offered only to high-risk population at this point in time with appropriate counseling. The secondary preventive strategies would be supplementing high-dose calcium 1.5 to 2 grams per day, as well as starting aspirin at the dose of 150 milligram per day as early as 11 to 14 weeks up to 36 weeks. Large multicentric studies are required to identify ideal combination of markers that can be used for routine screening in a low-risk population. Thank you.
Okay, chalo, we'll start. I hope I'm audible, visible. So the voice is clear.
Yes.
So we'll start.
Dr. Anu to take over, please.
Yeah, thank you. So the host had muted me, ma'am. I couldn't change over. Thank you, Dr. Smita, for that elaborate presentation on and very, very lucid presentation on screening of preeclampsia and why it should be done and what are the pluses and minuses about it. Now we go on to the role of biomarkers in the prediction and prognostication of adverse maternal and perinatal outcome in preeclampsia as a panel discussion. I invite the moderator, Dr. Revati Rajan, and also all the panelists, Dr. Manisha Kumar, Dr. Srimati Rajan, Dr. Nagaratnama, and Dr. Sharvana Kumar onto the dais. Also, I would invite as the expert review by our event chair, Dr. Sarosh Rana. Thank you all. Please, let's start the panel discussion.
Sure. Let me share my slides. I hope my slides are visible.
Yes, ma'am. Nagaratnama, madam, in front of your screen, there is something obstructing. Yeah, I think.
Yeah, oh, my hand, I think, my
Yes.
hand.
Okay, ma'am. Now it's fine. Now it's fine. Thank you.
Thank you so much for the prelude, Anu. And I think we had a wonderful session by Dr. Smita telling us all about screening for preeclampsia, which will again probably help us for some of the discussions as part of the panel. And as the Secretary for the Society for Maternal Fetal Medicine India, I warmly welcome all the delegates present here, the esteemed faculty, Dr. Sarosh Rana, who's joined in all the way from the United States at the VRs, and of course, some of the delegates from Bangladesh as well. And it's going to be a very interesting and a novel concept that we're going to discuss. To start with, let me ask some basic questions, because this is something that, a concept which is recently introduced, and, a lot of clinicians are still not very aware about what the biomarkers can do. The whole idea of using the biomarkers is to predict and prognosticate so that we can avoid criticality and save our preeclamptic mothers and their unborn. To start with the discussion, we have some of the basic questions like, what are biomarkers? This question is to Dr. Srimati. How are they useful, especially in the context of preeclampsia screening and surveillance?
Yeah. Thank you, Dr. Revati. So basically, biomarkers, there are various definitions, but I think if you want to understand what a biomarker is, it is basically a characteristic which you can objectively measure and you can evaluate it. This is an indicator of, it could be a normal process or it could be an indicator of an abnormal process of a disease. And basically, we have to be able to consistently measure it. And if you're able to do it, then it could predict the onset of a disease. So basically in screening or we could be able to diagnose the disease. We would be able to then evaluate the effect of various treatments and see how the biomarkers are changing. So in these ways, it could be useful for screening, it could be useful for surveillance, and it could also be useful for predicting the severity of the disease. So that is the standard, ideal characteristic of a biomarker. Yes, and moving on, in preeclampsia, do you think biomarkers should be done? See, basically, we all know preeclampsia is a syndrome, and it is a placental angiogenic disease. So basically, there's still two schools of thought. One, we see it's probably some maladaptation of the maternal system, and two is obviously placental dysfunction. So if you look at endothelial damage, or if you look at angiogenic or anti-angiogenic markers from the placenta, so basically using that as a biomarker, we would be able to, sort of have an ideal screening or a surveillance strategy for preeclampsia, definitely. And there are various biomarkers which have been proposed. As Dr. Smita was already saying, we have PLGF, which is already being used as a screening technique. So PLGF is also being used as a rule-in and a rule-out, as either a point of care or as the proper assay. We also have SFILT and PLGF ratio. So basically, if you add an SFILT to that, because this is going to be an anti-angiogenic, whereas PLGF is going to be angiogenic, so having a ratio is going to be more helpful. And this has been again trialed out both as a screening strategy from about 20 weeks onwards, as well as to predict and prognosticate. Soluble endoglin, there have been lots of studies which have shown that a ratio of PLGF or endoglin or SFILT and endoglin would be very helpful. There has also been some studies on pro-BNF and SFILT, and this is obviously a maternal marker, which could again be very helpful in predicting and prognosticating the disease severity. So in this way, I would say, yes, definitely, we would be able to use it as a screening technique, as a surveillance, and definitely as a sort of a predictor, because generally these biomarkers, if you look at the stage theory of development of preeclampsia, they usually are sort of seen in the blood maybe at least 4 to 5 weeks before the onset. So we would be able to use it as a surveillance, and maybe in future also as a rule-in, because there is definite evidence for ruling out up to 99% negative predictive value. But if you're able to use it as a rule-in, still the positive predictive value is about 60%. But hopefully moving on, we will have a combination of biomarkers. We'll have a combination of biomarkers as well as clinical parameters, which would probably be more useful in future. I hope that answers the question.
Thank you so much, Dr. Srimati. And I think Dr. Srimati has taken us through what is the rationale, what are biomarkers generally, and what is the rationale of using the biomarkers in probably predicting the root cause, which could probably, we probably assume it is endothelial dysfunction, which is worsened because of, this androgenic imbalance, which probably can be predicted with the markers like the PLGF or the ratio, the SBIT1 PLGF, the soluble form of the tyrosine kinase receptor. Just a little bit on the VEGF. VEGF is a homodynamic disulfide-linked glycoprotein. VEGF family has PLGF, A, B, C, and D, and A is nothing but the PLGF. And PLGF is the angiogenic factor, which is important for vasculogenesis. The SFIT1 is nothing but the soluble form of VEGFR1, and it lacks transmembrane and cytoplasmic domains, and it circulates freely and acts as a potent VEGF and PLGF antagonist. We are looking at those markers which have been used clinically, because I know there are multiple biomarkers which are available, but some of them which have been tested over a few decades have been the PLGF as well as the SBIT1 PLGF ratio. And recently, we also have the glycosylated fibronectin, which is coming in as a point of care test. And we have quite a few evidences, like for instance, we have this Dr. Leona Poon's article where she's actually given importance to screening, where and adding a biomarker can be really useful to identify those women at risk. in the first trimester of pregnancy. And of course, we have this wonderful article which says that, yes, you can use SVIT1 and PLGF as an important predictor of placental dysfunction, and it can be probably detected several weeks before the onset of pregnancy complications. We are really fortunate to have one of the pioneer researchers in the world, Dr. Sarosh Rana, who is part of this whole discussion. And as an expert, I'm going to probably call her in the middle after we finish about 5 questions to probably ask her to tell her views about the biomarkers. I think with this brief introduction, we move on to the next important question. What are the clinical implications of preeclampsia? And I mean, we also would want you to tell us, why is preeclampsia so difficult to handle? What are the risk factors? How is preeclampsia different in our country compared to the rest of the world? Is there problems with respect to different kinds of factors, risk factors complicating this particular disease? What is the incidence like in our country? Why do we dread its occurrence so much? To answer this question, we have Dr. Nagaratnamma, who is a professor and HOD of Rajarajeshwari Medical College, who's done a lot of work herself in the first trimester screening on preeclampsia. So, madam, in your experience, why do we dread preeclampsia so much? I think she has to unmute herself. Madam, can you please unmute yourself? Yes.
Can you hear?
Yes, madam, we can hear.
Huh?
Yes, madam, we can hear you.
Yeah, because that even your voice was a little not that audible.
Can you hear me now?
So thank you, Revati and Prakash Mehta, for giving me an opportunity to be part of this webinar. So we know that preeclampsia complicates 5 to 8% of the pregnancies and is one of the leading cause of maternal mortality, as high as 12%. And there are various risk factors associated with the clinical implications of preeclampsia. So that would be couple related is primiparity, paternity and pregnancy after donor insemination or donor embryo transfer, and dangerous male partner. And also there are maternal, which are maternal and pregnancy related complications like extremes of age, less than 19 years and more than 35 years, obesity and diabetes, multifetal pregnancy, previous history of preeclampsia, family history of preeclampsia, chronic hypertension, renal disease, and pre-existing thrombophilias, SLE, APLA, and also long intra-pregnancy interval of more than 7 to 10 years. When associated with these risk factors, it can lead to life-threatening or devastating complications like maternal eclampsia, HELP syndrome, which accounts for about 10 to 20%, eclampsia 7%, and abruptio placenta 7%. There can be pulmonary edema, acute renal failure, and the intracranial bleeding leading to neurological impairments, visual disturbances like cortical blindness, scotomas, DIC, and maternal death, and also it contributes to perinatal mortality. Again, the fetal complications includes oligamias, fetal growth restrictions, prematurity because of iatrogenic preterm delivery, and intrauterine fetal device, and the long NICU stay, which again accounts for these implications of preeclampsia, and lastly, the maternal death. Revati, you would like to add on to it?
Yes, ma'am. I think she has covered most of it. And we are also concerned about the atypical preeclampsia.
Yeah,
where
atypical,
the onset
yeah.
is less than 20 weeks or after 48 hours of delivery. Symptoms of preeclampsia without hypertension or proteinuria, which is not the typical form of the disease, which is again something that can catch the clinician unawares. And we're also worried about the early onset preeclampsia. We don't want to deliver these women much earlier, and the cost that would be incurred for the NICU stay would be huge, especially in our country. And late onset preeclampsia is also adding on to the disease burden. And delivery beyond 37 weeks. Are we supposed to be delivering all the hypertensive women at 37 weeks? Can we probably optimize the outcomes by probably, taking them up to 39 weeks safely is another question that we are really worried about. So definitely this article, which was actually published in 2009, says that the incidence of preeclampsia is estimated to be 7 times higher in developing country like ours. In fact, you have this public health article, which says, from the Public Health Survey of India, which says that it could be as varied as 33% in Haryana to about 87.5% in Tripura, especially in the northeastern states, which is a very, very scary thing. And, most of these cases may not have been properly reported. And most of us are scared because delivery is the only definitive treatment. We have to deliver them to probably, at the right time, not necessarily early, and so as to optimize the mother as well as the baby's outcomes. And low dose aspirin is recommended for prophylaxis in high risk women. It's something that we all concur. But yes, preeclampsia is definitely a deadly disease and some with serious implications across the country. So it is time that we empower ourselves to handle this disease in a better way so that we can optimize outcomes. So with this background, we move on to our next concern. What are the loopholes in the clinical definition? I'm talking only about the clinical definition and conventional methods of surveillance for preeclampsia, Dr. Saravana Kumar. And
Yeah.
this,
Yeah. Good morning, everyone. Thank you. Thank you for inviting me. The thing is, as you told, there's a varied representation of preeclampsia in Tripura and other places. So why this happens is because there's no uniform definition and there's no proper, the conventional methods are always distracting us. So I see a patient who comes with just a pedal edema with branded as a preeclampsia, or I see a patient who comes from a PHC with a organ damage, which has not been diagnosed earlier. And so they come where an intervention before could have helped the patient a lot. So that is why we need a uniform definition, because at some point of time, the proteinuria, 2+ proteinuria was considered as severe preeclampsia, and then they changed, and then all these, the low dose aspirin, that was initially 18 milligram, now it has been 150 milligram. One thing is we have to update ourselves and then teach our postgraduate as well as other people who are in the nuances of treating a preeclampsia. Otherwise, we see patients with complications. That's very important.
Thank you so much for that answer, Dr. Saravana Kumar. And he comes from Salem. The best part of this panel is we have panelists from across the country, from north, south, with an equal representation. So we have points of view from each one of them. Yes, the current diagnosis of preeclampsia with the existing clinical guidelines is a big challenge if you're looking at only high blood pressure and proteinuria and premonitory signs and symptoms. Uniformity of definition is something that we need to really think about, and that's the whole idea of getting the PENI course in, so that we have all the definitions and the understanding in place. And I'm glad that the recent ISHIP definition includes angiogenic imbalance. So you have this where the uteroplacental dysfunction could be either placental abruption, angiogenic imbalance, fetal growth restriction, abnormal uterine umbilical artery, Doppler waveform, etc. So including this angiogenic imbalance will give that window to the clinician to identify preeclampsia much before the clinical signs and symptoms can arise. So this could probably take us that extra mile from just relying on the clinical factors, and maybe this test could guide us a little better. And this is more so important in a discussion like this, where we're talking about the biomarkers. So, and we also have this ISHIP 2021 discussion where they have highlighted that an angiogenic imbalance is assessed by a reduced PLGF, which is less than the 5th centile for gestational age, or increase the split-1 PLGF ratio of more than 38 by the Roche assay, has been actively evaluated for its role in making an earlier diagnosis of preeclampsia, not necessarily based only on the clinical factors and the premonitory signs and symptoms, and based on the presence of uteroplacental dysfunction. So we have a guideline in place which endorses the biomarker, which is probably reassuring. Now, with this, we move on to the next question. This is to Dr. Manisha Kumar. She's participating all the way from Delhi. So, Dr. Manisha, could you please enumerate the role of biomarkers for screening in preeclampsia? And before she answers this question, let me tell you that she's done a lot of work and she's published her study based on the screening with the biomarkers from the Indian perspective. You could also probably highlight this during the course of our discussion, Dr. Manisha.
Yes, thank you so much for inviting me here, and it's so nice to be here. So basically, the role of biomarkers in preeclampsia, we have to remember that it's not only biomarkers. Before that comes the maternal factors and mean arterial pressure, and then the biomarkers. So all these three things together make the difference. Biomarkers boost the sensitivity and specificity to a lot of extent. So what are the biomarkers? The biomarkers are PAPE, PLGF, SFLT, PLGF ratio. So basically, once the PLGF came, the PAPE decreased in its significance. So we have to remember this. Now, when we are talking about screening, as I said, all these things, and plus the uterine artery PI is important. So all these together, this is called triple test by the recent coming up of FMF. This term has come. So when we talk about the biomarkers, we can use it by using a software which is there by FMF. So in that you can put the value of the biomarker, and then you can get the sensitivity and specificity and the detection rate. Whatever is more than 1 in 100, if you call it a positive thing. So basically, the biomarker PLGF to be used as screening at around in the first trimester boosts the sensitivity and the detection rate and decreases the false positivity to a large extent, and it is quite helpful here. So this is basically the role of biomarker, increasing the detection rate and decreasing the false positive rate.
Yes, Dr. Manisha, I think she's probably emphasized the role of adding the biomarkers along with the uterine artery PI and the MAP and the conventional historical maternal risk factors to probably help us to screen women who probably would develop preeclampsia much better, especially the early onset types. And we could also have the intervention in place. We could probably put them on aspirin, give them on calcium supplementation, and this would go a long way in preventing the early onset disease. And this is also endorsed by the FIGO recommendations. In fact, FIGO allows for universal screening, and if possible with all these factors, or at least with some of these factors. So if you do not have the expertise to get the uterine artery Doppler done, because it could be somebody has to be trained to do that, or if you're not able to measure the biomarker, you can still identify these women by using the clinical factors and adding on the MAP. And it also clearly says that we can use it even in twins. But however, the high detection rate can also be complicated by a high screen positivity rate in twins.
So the good thing about the fetal medicine foundation software is that if you don't have PLGF, you can use PAPE, whatever is being used in Down syndrome. So whatever you have, you can use that. You can use only maternal factors and MAP. You can use maternal factors, MAP, and uterine artery if you don't have biomarkers, then also it will do. So of course, the sensitivity and specificity will vary, but it is useful in any situation. So that is good in the FMF software that you have shown.
The whole idea of using more markers is that, the sensitivity of prediction could be as high as, say, 80 to 90% with a false positivity of about 5 to 10%. And if you're using all the 4 markers, it could go to about 96% also. But there is a recent article which has actually come in, I think, which we could probably discuss, saying that it is not very mandatory for us to use PAPE, like what you said, and we could probably use only the PLGF along with the uterinatrian map without a great compromise on the sensitivity of predictions.
So one more thing that is important here is that whatever sensitivity and specificity we are saying is for early onset preeclampsia.
Absolutely.
It is not the same for in general late onset preeclampsia or hypertensive disorders in pregnancy. So basically, because early onset preeclampsia is most dangerous, and these markers are more for early onset preeclampsia rather than normal preeclampsia or hypertensive disorders of pregnancy.
Absolutely. So we have much more of the disease beyond the early onset because we are just capturing only a small portion of this disease. And aspirin can only prevent 60% of cases of the early disease if picked up early. So there's a lot of work that we have to do with surveillance beyond the first trimester. So it's not the end all that you screen women in the first trimester and forget it. You have to probably follow the disease and map the disease much further to actually optimize outcomes. And that's how our discussion is going to move further. So we've been talking a lot about screening. We've talked about the use of biomarkers in screening. Now moving to the second and the third trimesters, Dr. Srimati, can you please tell us what is the role of biomarkers in the prediction and prognostication of maternal and adverse maternal and perinatal outcomes in preeclampsia? And post this question, I would invite Dr. Sarosh Rana to probably tell us some valuable reviews about what she felt about the panel so far. And she could also narrate her experiences as well.
Thank you, Dr. Revati. I mean, there are a few situations wherein you could be using biomarkers. This could be a routine screening in the second and the third trimester, just to stratify their risk, whether they are low risk or high risk. So there are some studies which are looking at having a UAD plus maybe SFELT and PLGF or a combination with endoglin, so that we would be able to stratify them, even if it's a low risk population. And there are also, though not many studies, there are some sort of thoughts about using it maybe in the late third trimester, 28 weeks or 34 weeks, as a one-off test for all women, so that we'd be able to risk stratify them. But that is in general. But if you look at the high-risk population, they could be high risk because of the enhanced FTS, or they could be women with background high-risk problems like CKD, etc. So in these women, doing a surveillance, serial surveillance to see whether they are going to develop the disease. So this would be very helpful, so that we can use it as a prediction of them developing a disease. The second aspect would be when we have diagnostic dilemmas, as I'm sure you're going to bring it out in the case presentations. We would definitely be again use the biomarkers, so that if women come in with atypical presentations, using an SFELT PLGF ratio, either to rule in or rule out preeclampsia. So that would be a very good use of the biomarkers. Of course, in sort of predicting the severity of the complications, planning their care, whether they need to be admitted, whether they need to be delivered. This again, the biomarkers would be very helpful. And as you rightly brought about, whether we should deliver or whether we could prolong the pregnancy in women who have already developed the disease, so as to plan the delivery timing. So in all these aspects, for both predicting the onset of the disease as well as prognosticating, planning the surveillance, as well as planning the delivery, SFELT PLGF ratio to a great extent, and PLGF and endoglin also can be used.
Thank you, Dr. Srimati. And of course, we have the iSHIP 2021 guideline, which clearly emphasizes that in women who are suspected preeclampsia, androgenic imbalance has a high negative predictive value in ruling out and development of proteinuria preeclampsia within 7 days. And I have seen this in my study as well. Adverse maternal outcomes within 14 days, or delivery with preeclampsia within 14 days when suspected preeclampsia is primarily related to hypertension, but not when FGR is a prominent reason. Use of androgenic markers to guide care may reduce adverse maternal outcomes, to a great extent, and you can, by making a timely diagnosis of preeclampsia by an average of about 2 days, you can identify women at increased risk of peripartum severe maternal morbidity, including postnatal hypertension, and be cost saving, especially this has been proven in several countries like in the UK. So similar findings are emerging from less resource settings like ours, like the robust study that we just published. And prediction of adverse outcomes may be improved by combining androgenic markers with other clinical routine, laboratory, and ultrasonographic data. So with this, I would invite Dr. Sarosh Rana to give her review and take us forward from here.
Thanks, Revati. So yeah, I would pretty much concur with what you guys have been discussing. I mean, we wrote these guidelines, and I think we were really careful in terms of kind of, especially when you're predicting something in the second and third trimester, I would say have like a timeline to it. So you can't like measure a biomarker at 22 weeks and try to predict something that's going to happen at 37 weeks. That's now, at least that's now not how the ratio works. I know PLGF is a little bit different because the levels of PLGF go down quite significantly even early in pregnancy, and they will just stay down. While soluble FLIT is, and that's why I kind of pretty much all the studies that we have done, we've always used the soluble FLIT PLGF ratio, because soluble FLIT is kind of goes up in maternal circulation like just before. So 2 weeks before, 4 weeks before an adverse outcome is happening. So if you measure a person's PLGF at like 24 weeks, she may not develop adverse outcomes for weeks and weeks to come. But I think soluble FLIT PLGF actually gives you a better idea of when the maternal adverse outcomes are going to happen. So these are obviously based on really robust studies. The first statement, when it says development of proteinuric preeclampsia, that was based on the prognosis study, where they predicted development of preeclampsia, and it was all preeclampsia within 7 days. And then they had a rule-in test for preeclampsia within 14 days. The next statement, which says adverse maternal outcomes, and I think in the context of, and somebody earlier mentioned that we keep changing the definition. So I think in the context when the definitions of preeclampsia is changing, we can at least all come together as to what are the common adverse outcomes that are associated with preeclampsia and trying to predict that. Because ultimately, who cares about the diagnosis? You really care about, is the mother at risk for preterm delivery? Is she at risk for abruption? Is the baby at risk for IUFD? Is she at risk for developing HELLP syndrome, stroke, or eclampsia? So that is based on most of our studies where we looked at adverse maternal outcomes, again, happening within a week or within 2 weeks. And then obviously delivery related to preeclampsia. So there's a very high correlation between high soluble FLIT PLGF ratio and quick delivery versus patients who have a low soluble FLIT PLGF ratio. They actually can stay pregnant for a very long time. So one thing that I wanted to mention is, this was obviously the prognosis study, which was published in the New England Journal of Medicine by Stefan and his group. And there they found that patients who have a ratio of less than 38. So these was a group of patients who were coming in with suspected preeclampsia. So this kind of term, suspected preeclampsia, has been used quite extensively in literature. And this is essentially any pregnant patient that you are suspecting preeclampsia. So she could be at high risk in your clinic. So she could have chronic hypertension. She could have diabetes, she could have proteinuria, she could have edema, she could have shortness of breath, headache, like any of these non-specific signs and symptoms. If you actually take those patients, so they're definitely, because you're suspecting preeclampsia, you're going to get some labs done, you're going to check her blood pressure, you're going to check her protein. But at the same time, actually, if you look at the soluble FLIT PLGF ratio, there is a very high correlation of a high ratio. So if you go to the previous slide, a low ratio actually rules out preeclampsia with a 99.3% ruling out within 1 week and 94% ruling out within 4 weeks. So it is a very, very good rule out test in terms of if you're using it at the onset. So if somebody comes in with suspicion of preeclampsia, you measure the soluble FLIT PLGF ratio. If your ratio is low, that person is at low risk to develop preeclampsia within 1 to 2 weeks, and also actually low risk to develop any adverse maternal outcomes. On the flip side, if you go to the next slide, if you have a high soluble FLIT PLGF ratio, and this we've shown previously, and obviously these guys have shown as well, is that they're at much higher risk for for example, 3-fold higher risk to have imminent delivery, much shorter evaluation to delivery timing. So if you have a high soluble FLIT PLGF ratio, there's a very high chance you're going to be delivered in the next few days. Very high rates of preterm delivery. And also look at this, the remaining pregnancy duration was very different. So if you have a low ratio, if you have a high ratio, your pregnancy is ended in 17 days, versus if you have a low ratio, your pregnancy goes for a long time. So I think the way I look at it, and we just finished a study, is going to be published hopefully soon. It's a multi-site US study that we just finished. We actually took patients So previously we were looking at patients who were in triage, for example. So this is, this is one of the papers that we wrote, is we were looking at patients who were coming to a specific clinic or coming to a specific place to be evaluated for preeclampsia. And there we looked at patients who were at risk to develop severe preeclampsia, for example, in this study. But we actually just finished a study whereby we took patients who were already admitted to the hospital with hypertension, with superimposed preeclampsia, with whatever kind of hypertensive disorder. And we checked their soluble fluid PLF ratio on admission. And we predicted development of severe preeclampsia delivery within the next 2 weeks. So that was kind of the one of the biggest studies that is going to come out of US. They enrolled about 1,000 patients. The other personal utility I feel is, especially in the context of triage, is what is the utility of biomarkers on top of an existing diagnosis. So somebody may ask a question, somebody comes in, she already has hypertension, she already has proteinuria. Do the biomarkers actually add any additive value? And the answer is yes. That paper we just submitted to AJOG is going to come out. There's a massive improvement in your prediction of severe pre-E, prediction of adverse outcomes, if you add biomarkers to your existing whatever criteria you're using. So if you're using blood pressure, protein labs, and you add biomarkers, in all the scenarios that we ran the analysis, the biomarkers added value for prediction of adverse outcomes in these patients. So definitely, I think, you guys are lucky you have access to the markers. I would say use it as a negative test. If you're evaluating preeclampsia, use it as a positive test. The only caveat I would have is that, and I think Revati was going to the next opinion paper we just wrote with as to how to use, and I would highly recommend, I hope people have access to this. So this, these are the ESC guidelines. This is actually a paper that we just wrote, and I can put that in the chat, Revati, about how to use the biomarkers in different scenarios. So one thing we kind of really are staying back is to deliver patients entirely on the biomarkers. So we should not do that, right? So we should measure the biomarkers, and if it's high, you can admit the patient, you can give her steroids, you can talk to her and tell her she's at high risk, depending on how high the biomarker is. But there's still some latency between you measure the biomarker and the delivery. So especially in the preterm context, I think we should not use the biomarker information alone to deliver patients. We should use other information along with the biomarkers. So the severity of hypertension, fetal heart rate tracing, evidence of abruption, labor, maternal symptoms should be used for delivery primarily. So that is the only thing I would say, is that we should not use biomarkers by themselves to determine the timing of delivery. Even if we know that the patient is at high risk, so obviously we treat her, give her magnesium, whatever you need to do. That would be my only kind of caveat. Somebody earlier said that we could, decide the timing of delivery. I would not decide the timing of delivery just based on biomarkers. We obviously use the other clinical criteria that we use to decide delivery.
Sure, Dr. Sarosh. I think that was a very extensive review of what we did till now. And you've brought about certain important points that, yes, biomarkers are definitely going to add value to the existing clinical diagnosis. We're not going to just rely on the biomarkers. Biomarkers can definitely going to tell us which of the women that we have to probably concentrate and probably deliver them a little earlier or optimally at the right time so as to prevent complications like, the dreaded abruption, pulmonary edema, and of course, the intrauterine fetal demise. So I think she has completely told us from the global perspective. With this, we move on to the next question to Dr. Nagaratnamma. Could you please highlight some of, I think Dr. Saroshana has covered most of the global evidences. Could you please tell us from your practice, because I know that you're doing a study in the first trimester for screening. So the Indian evidences as well to probably tell us how the utility of these biomarkers in the prediction and prognostication of adverse maternal and perinatal outcomes. Dr. Nagaratna? Is Dr. Nagaratna? Yes, ma'am. Yes, ma'am. Can you please tell us a few evidences? Maybe you can concentrate more.
We have good number of global as well as our South Indian studies for early first trimester screening as well as for the second and third trimester screening. So we have the London Tertiary Care Hospital study which was done in 2017 to 19, where they included the 7,000 patients were included for nice risk-based guidance, and another 5,000 for the Fetal Medicine Foundation algorithm, which combined maternal risk factors, blood pressure, Pape and uterine artery, Doppler indices in the first trimester. And they concluded that first trimester combined screening for pre-eclampsia is both feasible and effective in a public healthcare setting. And definitely there was a significant reduction in the prevalence of preterm pre-eclampsia with the intervention of aspirin once they become PE positive. Similarly, a South Indian study was done in New Delhi, where there was a so they used the Fetal Medicine Foundation algorithm, and they also found that there was a significant reduction in the pre-eclampsia with the intervention. So here again, there was a robust study. There was a robust study by the Dr. Revati, I think, and also there was a prognosis study, which was a landmark study, and they are also used apart from only first trimester screening, second and third trimester screening can also be noted by by doing the S-split and PLGF ratio, where they can detect the PE within 1 week of occurrence, and they can avoid iatrogenic preterm deliveries, etc., and also the intrauterine fetal demise. So similar study was done in our India by Dr. Revati and her team, and I think she is going to explain to you regarding that. She'll be a better person to explain. And glycosylated fibronectin also was done in one study was done in India, where they found, even though it may not be that feasible to do the fibronectin alone, but definitely it has given some improvement in the this thing, but it needs further studies whether we can combine with other biomarkers. I think Revati, can you highlight on your study?
Yes, madam. Thank you so much for taking us from the first trimester onwards. You have highlighted that there have been studies in India where we've actually used the combined test for first trimester screening, and we've actually found some good benefit. And as far as the robust study goes, we did this study and we published it in the late part of 2020 or early part of 2021. And what we were trying to do, Dr. Saroshana mentored this, and what we were trying to do is find out how many women who were hypertensive were probably going to develop the severe form of preeclampsia and probably have adverse outcomes. Because of the constraint of time, I don't think I'll be able to tell you the result, the whole study completely. The study was the real life outpatient biomarker use. So we were using this in clinics and not necessarily in tertiary care hospitals. And we were trying to manage hypertensive pregnancies in the third trimester in low resource setting, that is in a clinic which does not really have an ICU or an ICU facility, and try to monitor these patients. And the best part of this study was we did serial surveillance. So we looked at these women from 28 weeks onwards, all singleton hypertensive pregnancies who agreed to participate in the study. Every 2 weeks, we measured the SPIT1 BLGF ratio. And we classified them as low risk, intermediate risk, and high risk. This is very, very important. So anybody who was less than 33 was considered to be low risk. Anybody between 33 and 85 was considered to be intermediate risk, and above 85 was considered to be high risk. This was less than 34 weeks, and beyond 34 weeks, we used a cutoff of 110. So we kept all that in mind, that we were, we were looking at the ratio, we were looking at different cutoffs depending on the gestational ages, which would probably help us with better sensitivity and specificity of prediction. So basically, this graph will tell you about all those women. So every woman had more than one test, and suppose somebody turned intermediate positive. If somebody was negative, we repeated the test every 2 weeks. But if somebody was intermediate positive, that is between 33 and 85 or 33 and 110, we did the test after a week. And suppose somebody turned positive, we stopped doing the test. So anybody who turned positive, we're looking at about 103 encounters of women who had the test and were considered to be screen negative. 100% of these women did not develop severe or preeclampsia with severe features in the next 1 week, and that was very reassuring. We had all kinds of people. We had women who had history of previous IUFDs. We had women who were elderly, ART conceptions, chronic kidney disease, autoimmune background. So all of them had reached 28 weeks, and when we did this test, and we found that they were less than 33. Uh, in fact, we could probably send them home and continue our regular surveillance. And we also found that somebody who was the intermediate positive category, that was between 33 and 85, 86, if they were negative, 86% of the times they were not going to develop preeclampsia with severe features. And somebody who was more than 85, 60% of these individuals were going to develop preeclampsia with severe features. So the best part to the clinician was we knew whom to admit, not admit those women who were not going to get sick, send them home. It was a lot of economic benefit and a lot of emotional benefit also, and only admitted those women who would probably develop adverse outcomes. And we averted the outcomes because we were prepared, because we had admitted them in a tertiary care hospital. We had the neonatologist, we had the blood bank, we had the ICU. We were well prepared that this woman was probably going to develop a complication. And that is definitely a very, very important point that I would want to stress. And we should probably do bigger studies in our country to make this a part of our care of how we are trying to probably stratify these women to make more meaning to our standard clinical practice. Of course, the PLD
And Revati,
test.
here I would
Yes.
like to.
Yes, madam. Please
Yeah.
go ahead. Yes,
No, I
madam,
would
please go
like to
ahead.
tell about my studies. I'm doing the Saint-Genetic factors in the first trimester screening by the FIGO recommended, FIGO-based, risk-based guidance. And I have come to the end of the study. It is a clinical trial of RGHS, and it's been quite a promising study. So I'll be publishing shortly about that study, and I have found a good outcome with the aspirin intervention and other monitoring the for fetal growth restriction, other things, and timely delivery. So really the outcome is quite good. I think first trimester screening, we can combine the pre-eclampsia screening. It's really a good tool and a good biomarker.
Yes, madam. So even if you're looking at this study, which they did on the South Asian population, they found that the incidence of preeclampsia and preterm PE were as much as 3.1% and 1.34%. And PAPI and PLGF mom distribution medians were 0.36 and 0.87 mom, and significantly deviated from one mom. And what they actually found was, the unadjusted DR using more than 1 in 100 threshold was 76%. So estimated DRs for a fixed 10% false positive rate range from 52.5% to 80%, depending on the biomarker combination after recentering moms and adjusting for aspirin use. So the FMF, they found that the FMF algorithm, while performing satisfactorily, could still be further improved to ensure that biophysical and biochemical markers are correctly adjusted for indigenous South Asian population. So we definitely need our own standards. We need our own references so as to improve the performance of these tests. And like how Dr. Nagaratnama said, it is very, very important that we screen these women with multiple parameters. We take their history, we look at the ultranatal Doppler, we put their biomarkers, look at the map, and then finally not leave them at that level, because please understand these are only going to pick up early onset preeclampsia, and aspirin is only going to prevent 60% of the cases. So we have to still map them beyond this and go to the second and third trimester, map the disease, identify those women who are still prone to adverse outcomes, and probably monitor them and do the appropriate clinical surveillance. Never use only biomarkers to make a decision on delivery, like Dr. Sarosh Rana reiterated. So with all these points in mind, we can definitely optimize outcomes of our preeclamptic women. So moving ahead, I think we've had a big discussion about what the global as well as the Indian evidence say about the biomarkers and their use. And of course, I would want to ask this question to the next question, the role of biomarkers in the prediction of postpartum hypertension, because we're also worried about that. A lot of these women don't come back to us sometimes after 1 week of delivery. They come to us throwing a fit. So, and also about the future cardiovascular implications. So, this question is to Dr. Saravana Kumar. Can you please?
Yeah, this is a very important question because as you told, people come to us with fits in after delivery. That's because we have not stratified them as to whether they are prone for complications. So if we have a biomarker to predict their complication rate or their end organ damage, then probably we'll be able to predict those people and ask them to stay in the hospital, or we can stratify them to go back to their homes if nothing is found to be abnormal. And we are seeing that there is 29% of the women who had hypertension 1 year after pre-eclampsia. This is an important strata, because once we find that this many people, almost 1/4 to 1/3 of our women develop hypertension after 1 year of pre-eclampsia, that means that we have to put them in loop so that we will have at least a sort of helping them out in their next pregnancy, or at least make a lifestyle modifications for them. So, and continue with their antihypertensive medications. So where we see this obliteration of this ratio, or the change in the ratio, that tells that these biomarkers are going to help us in predicting how they are going to develop. Whether this study shows that angiogenic imbalance in pregnancies is complicated with preeclampsia and signs of cardiovascular impairment in long term after pregnancy. That's very important to know and use uniformly for all our patients.
Yes, thanks, Dr. Saravana Kumar. There is a study. We are talking about whether we can use androgenic biomarkers to predict postpartum hypertension. What is actually known as women with previous preeclampsia. This is a study where they evaluated these women 1 year postpartum. Androgenic markers were not associated with hypertension 1 year after preeclampsia. However, women with postpartum hypertension had displayed lower PLGF values during their pregnancy. So this is something that we should probably keep in mind. Suppose you're looking at those women and you have measured their biomarkers. Definitely women with a low PLGF value are more prone to postpartum hypertension. This is something that we need to keep in mind. And of course, this could also, these markers, when they are high, could also indicate that these women can have cardiovascular implications beyond delivery. So we've seen that there's a study which was actually published in Hypertension, and this is the American Heart Association study. And what was actually told was a low level of PLGF was associated with high blood pressures, low HDLs, increased global longitudinal strain in the heart, and definitely there is an increased carotid intimal thickness. And a high level of SWITch1 probably was associated with low HDL, a low level of apolipoprotein A1, so a lot of lipid disturbances, and of course, an increased left ventricular posterior wall thickness and increased carotid intimal wall thickness. So this tells us that these women are probably going to have the high level of these ratios because they already have a pre-existing problem, which is the endothelial dysfunction. And so we must probably catch these women and risk modulate them for life. So that is what is very, very important. And of course, these biomarkers, when positive, can indicate the possibility of postpartum hypertension immediately after delivery and also future cardiovascular risk. Dr. Sarosh Rana has done a lot of work in this field. Maybe at the end of this session, I would ask her to say a few points in this regard as well. Moving on, Dr. Sarosh Rana, do you want to add something on this? Okay.
No, the one thing I would say is that I think what it is that a soluble FLT PLGF ratio in pregnancy is just reflective of definitely soluble FLT is cardiotoxic. It's just like an endothelial. It causes significant endothelial dysfunction throughout the maternal circulation. I think it's a beautiful index of how bad your disease is. So rather than previously, if you look at epidemiological studies, women who have term preeclampsia have a lower prevalence of CVD, for example. Obviously, they have a higher prevalence of CVD than cardiovascular disease than women who had no preeclampsia. But if you look at women who have early onset preeclampsia or multiple preeclampsia, they have a much higher prevalence of cardiovascular disease. So I think these markers are reflective of how significantly abnormal your angiogenic profile is during pregnancy, and that amount of anti-angiogenic environment during preeclampsia, for example, for weeks and months, definitely causes cardiovascular damage. Even at the time we published and we looked at the global longitudinal strain with the maternal echo at the time of preeclampsia, and they definitely correlate with soluble fluid values. Now, what doesn't correlate, some of this is like your previous slide, is so if you were to measure soluble fluid and PLGF in patients at the time, like 1 year postpartum, there's actually no correlation between the prevalence of hypertension and their angiogenic profile 1 year postpartum. So clearly there are, what I believe, and there are lots of theories around it, is that it initiates the cardiovascular dysfunction. And then there are other proteins, cardiotoxic proteins that are also present in preeclampsia that perhaps perpetuate the cardiovascular dysfunction that is seen in these women throughout their life. So definitely there is, and also you have to remember that soluble fluid is essentially, and PLGF are in very high concentration during pregnancy because they're placental proteins. So they're not usually in such high concentrations in otherwise non-pregnant people. So yeah, so this is saying that you have an anti-angiogenic environment during pregnancy, which correlates with low PLGF, high soluble fluid, which will then correlate with long-term cardiovascular disease. So yeah, so this is good.
Yes, thank you so much, Professor Ghosh. And moving ahead, let me ask this question to Dr. Manisha. We've been discussing about how we can probably improve the detection of these women who are probably going to have adverse outcomes because of preeclampsia. And we're talking about biomarkers. So could you please describe the cost benefit which is accrued by surveillance with the biomarkers, Dr. Manisha? Is it worthwhile to add the biomarkers, and will this add value to our women in terms of the cost benefits?
Yeah. So we have to remember that the most important thing about the biomarker PLGF and SFLT is that it increases the negative predictive value. The negative predictive value is something that is the most important thing. So it will rule out like disease in many, and you need not follow them throughout the pregnancy. So if you see this nice evaluation study, you find that when you are using the novel approach, the true negatives increase and the false positives decrease. If I just give you a small example, like if you are taking the 1,000 women who have come as high risk because of their maternal factors, and you're following all of them up. So how much the cost it would increase of monitoring, of admitting them, and now if you are delivering them, then the prematurity. So all these costs would increase. And then at the end, what you will get is you will find only 3 patient who would come as positive, and rest 4, or like if you take it as 1 or 2, 3%, then rest 30-40% you would not diagnose at all. But if you are taking the biomarkers with sensitivity of 90%, 10 out of 9 women you are detecting, and at the same time you are following only 100 women, because the specificity is 90%. So the false positive is just 10%. So out of 1,000 women, you have selected 100 women or 110 women, you're following them. And out of them, only 9 of them would come as positive, and only 1 you would not detect. So this is the power of using biomarker, that you have to, follow less women, and that would improve the cost. And at the same time, your sensitivity would be very high.
Thank you so much, Dr. Manisha. I think you made a lot of sense. Like we, considering that our resources are not so much that we can probably look at every woman. At the same time, we don't want to be underdoing, in those women who are really going to get sick.
And it is more pertinent in our setup rather than.
Absolutely, absolutely. So we're looking at only those women who could mostly develop adverse outcomes due to preeclampsia, and probably not going to admit those women who are not going to probably have severe features. So, and this is also a very objective way of telling these women, because I've had a lot of illiterate women who really not understood, they don't know what the biomarkers are, but it takes a lot of counseling. You need to sit with them and tell them that this is the number and this number went up. So that is the reason we are a little worried, because they're not going to understand what preeclampsia is. So definitely what the biomarkers can do to us is it can increase the true negatives and reduce the false positives. And this can do a lot of benefit, in terms of utilizing the resources for the right set of people. And this has been demonstrated in many countries in the Europe. And I think Dr. Rana has also done a couple of studies. She's done, I think, she's researched on literally every little bit about the biomarkers. You name it and she's researched about it. So we have the references in hand. So with this, I think we have a fair enough idea of what these biomarkers are, how probably this can act as a novel addition to the conventional clinical armamentarium, and how it can probably do good both to the patient and to the clinician and as a country as a whole. Now we're probably going to understand these, through the cases. How are we going to probably identify women who are at risk using the biomarkers? And these cases, especially the second, third, and fourth, are from my robust study, the recruits of my study. I think one was not. Yeah, there are two cases as part of the robust study, and one was atypical preeclampsia. And I've also put in one test based on the combined screening in the first trimester so that our viewers could actually understand how you could use these biomarkers real time. So starting from the first trimester, this is to Dr. Manisha Kumar. We had a 27-year-old third gravida, para 1, live 1, abortion 1. She was a case of over diabetes on insulin, and she presented to the MFM OPD for risk assessment and surveillance plan at 12 weeks and 2 days as per her corrected expected date of delivery. Her relevant pointers in history, this was a very recent case that I managed. First pregnancy was in 2019 and it was a natural conception. She had history of threatened preterm labor at around 28 weeks of gestation. She was diagnosed gestational diabetes at that point of time, and she was started on insulin along with diet in view of recurrent ascending infections, which probably led to the threatened preterm labor. And it was appropriately treated with antibiotics. She was under domiciliary care, and thank God she settled for about a month in the hospital. And then in view of waxing and waning symptoms of preterm labor, she was still kept in the hospital for about a month. And then she was conservatively managed. She was at home, and somehow, she was taken up to 36 weeks. This was not with me. This was with the previous caregiver. And she had a spontaneous preterm birth, but it was a 2.6 kg boy, and the baby is doing well. The second time, it was in 2020, it was natural conception. It was a missed abortion at 10 to 12 weeks of gestation. There was history of fluctuating blood sugars in spite of being on insulin. This time, she was already on insulin in the first trimester. She was on irregular follow-up, and she was not on aspirin in both the pregnancies, and she had a missed abortion at around 10 to 12 weeks. Now, what happened in the third pregnancy? She actually met me at around 12 weeks and 2 days. She was already a case of over diabetes, and she was on insulin. She was on long-acting insulin since the beginning. There was bad glycemic control. The HbA1c was 8. The NT scan was done at around 13 weeks. There was no structural defects. The NT, NB, DV Doppler, as well as tricuspid Doppler was within normal limits. The uterine artery Doppler mean PI was 2.225, which was about 91st centile, because she came to me for risk modulation and surveillance plan. That's how we did the NT scan as well as the uterine artery Doppler. I also counseled her for the combined test, considering that she was diabetic and she had a previous missed abortion. A combined test for first trimester screening for pre-eclampsia, that is MAP plus uterine artery Doppler mean PI plus PAPI and PLGF was done, and it showed screen positive. It was 1 in 8 for early pre-eclampsia and 1 in 5 for late pre-eclampsia. This is how the report looked. You can see that she was positive risk for early pre-eclampsia. Okay, so the question to Dr. Manisha is, how would you evaluate this case further? So you have a lady who's had a previous threatened preterm birth. She has medical problems. She's an overt DM, bad glycemic control. She'd had a previous missed abortion, and now she comes to you with the result of the first, I mean, you've done a first trimester combined test, you've counseled her for that, and you find that she is high risk for early and late preeclampsia. It was a big risk. Now, how would you counsel the patient, and could you please outline further surveillance?
Yeah. So basically, she is a diabetic. She has got a high. So this is one of the major factors when we are looking at the NICE guidelines factors. And she has got a high BMI. And so that is also one of the important things. So, and regarding this pregnancy, we would like to make the glycemic control, correct it first. So that is our would be our first priority. But of course, we are going to get, as you have mentioned, I doubt whether we should do antiphospholipid antibody testing or not, because we know that she was a diabetic and not controlled and she had an abortion, maybe because of that. But yes, thyroid is important. We must get that test done and start her on ecosprin. So when we are advising ecosprin, we should be advising that it should be taken at a proper time, that is at bedtime, and proper dose, and compliance is very important. Once the compliance is not there, even if she's taking aspirin and not taking it in a right time or right dose, the effectiveness is not there. It reduces by half. So you have to tell her how important it is. And recently we have got few studies on exercise, how important is exercise. For her diabetes, it's important, and it's important for her pre-eclampsia also. So exercise, sleep, and in the second trimester, calcium. So all these things would be important. And apart from that, I would like, because we have already done PLGF once, maybe at 28, 30 weeks, I would like to get it done again, just to have an understanding how her preeclampsia is progressing, or if she is developed, even if she develops preeclampsia, or if she doesn't develop that, then whether she's going to have it and how safe we are to carry on in the third trimester. So that would be my major concern regarding hypertension and preeclampsia.
Sure, Dr. Manisha. What we actually found in her is, because she had a previous missed abortion and she was really positive for early preeclampsia, we did talk to her and we found that she was APLA and ANA negative. So it's not always thrombophilia. So endothelial dysfunction could be because of an endocrine problem. But we found that she was euthyroid, and all the problem had started because of her bad glycemic control. So we did switch over to a much better protocol on insulin. We looked at the regular and short-acting insulins, and we added aspirin because she was not on aspirin till then. And of course, like what you said, she has to be on close surveillance. We have to monitor her BPs, maybe get her into the SPIT1 PLGF monitoring protocols. We could probably start off as early as 24 to 26 weeks to monitor the disease, because aspirin is not going to prevent all the disease. Probably it's going to prevent 60% of the times, and then optimize our outcomes depending on what her ratio does, and probably get her into the hospital as early, as and when it demands, and deliver her right, and keep her mentally prepared for a possible tertiary care hospital delivery, the need for blood products, the NICU. So all this needs to be primed to her, because she's definitely at high risk for the disease. So definitely doing this test can give us that window where we can keep the patient primed, where we can equip ourselves and also make a difference to the disease, at least reduce the severity, though we cannot completely prevent the disease. So this is how a first trimester combined screening test can help. All right, moving forward, we have the second case. This case was probably included here just to understand that, yes, these biomarkers can help us rule out, atypical manifestations, or if you're worried about, you can actually differentiate help from other, mimics of HELP and severe preeclampsia, and probably avoid an unnecessary preterm delivery. This was not a recruit into the robust study, but this was another case which came in at the same time. So we had a 26-year-old primi gravida. She was married for 5 years. She was ANA positive and she was extended profile negative, she was over diabetes on diet, she was TPO positive, subclinical hypothyroid on thyroxine, and she had history of subchorionic hemorrhage in the first trimester. She was evaluated for a whole lot of autoimmune antibodies because she was married for 5 years. She was actually investigated in terms of primary infertility, and that's how we found that she was positive on the ANA. NT scan showed a mean uterine artery PI was 2.3. She was investigated for APLA and she was found to be incidentally beta-2 glycoprotein antibody IgM positive. She settled with low molecular weight heparin, 40 milligrams SC once daily. And she was also immunomodulated with steroids because she was ANA positive. She was given prednisolone 5 milligrams twice daily with HCQS 200 milligrams, one in the morning, one in the night, which could probably help stabilize the endothelial dysfunction. At 20 weeks of gestation, her SGOT, SDPT, which was a routine test because she was autoimmune, we did her liver functions, her renal functions, her complete hemogram. But her SGOT, SDPT was about 37 and 60 units, slightly on the higher side of normal. Her platelet count was 98,000 cells per cubic millimeter. She was beta-2 glycoprotein. It was understandable that her platelets would fluctuate. And her abdominal scan was perfectly normal. And we had to stop her aspirin at that point of time because her platelet count was a little on the lower side. But her uterine artery Doppler mean PI had normalized after we had started the low molecular weight heparin to about 1.37 at 20 weeks. And the fetal growth was normal and there was no obvious defects. Now, this patient went away to Bihar. She was not a literate woman. And she just went away to Bihar and she returned only after 6 weeks. So we did a scan for fetal growth, well-being, and extended defects when she came back, and it was normal. But when we did the SDOT, SDPT, because we knew that they were already on the higher side of normal, it was soaring high. It was something like 200 and 497 units per liter. The alkaline phosphatase was 269 units per liter. Rest of the LFT was normal. She was normotensive. The PT INR was within normal limits. HIV, HPSAJ, HCV, hepatitis A was done and it was normal limit. The PET profile was also within normal limits, except for that platelet count, which used to keep somewhere between 90,000 and 1 lakh. She was started on tablet ursodeoxycholic acid, 300 milligrams TID, with the benefit of doubt that she would have probably developed intrahepatic cholestasis. Parallelly, we actually did the autoimmune hepatitis profile, and she was positive for anti-Smith. So we knew that her liver functions had probably deranged in the second trimester, which could probably be attributed to her autoimmune problem. But then we did not have time to think, so we had to start UDCA just prior to doing this test. Then we continued monitoring her, and prophylactic steroids, betamethasone was given for fetal lung maturity at 28 weeks, anticipating that she might worsen anytime. And there was also an element of growth restriction which started at that point of time, though she was normotensive. Her SGOT, SDPT continued to be around 186 and 642 units per liter, and platelets dropped to 83,000, but her PT and INR was within normal limits. At that point of time, I had to really counsel her because she was really worried because she had taken opinions from a lot of other clinicians who said that because she was going into very high levels of liver enzymes, her platelets were dipping down, probably there was an overlapping health. She'd reached 28 weeks, there was growth restriction. So steroids had been given, so enough is enough, and we would probably deliver you. But then I told her, delivering her at 28 weeks, and which was kind of about a 1 kg baby, was not going to be, cost effective for her. So we said, okay, we have this test called the SPIT1 PLGF. Let's do this and try to find out whether you're really into help or not. And when we did the SPIT1 PLGF, it was 3, which was very, very reassuring. I had to really sit down and explain to her what it meant to do an SPIT1 PLGF. We did the growth scan at 30 weeks. It continued to show an AC lag of about 2 weeks with the expected fetal birth weight at around the 15th centile. The growth restriction was setting in. The fluid was also getting less. It was about 9.9. We upgraded her steroids, her regular dose steroids. We were consulting an immunologist at this point of time, as well as a gastroenterologist, who was also part of our care. And we had increased the steroids to about 10 milligrams in the morning and 1 milligram at night, and 5 milligrams at night. And we continue to monitor her bi-weekly with modified BPPs. We did weekly growth scans, bi-weekly platelets. We tried to make sure that the platelets were keeping about 80,000. We did her LFTs weekly, just to understand that, they were not going something like more than 1,000, or they were not doubling or something like that. And a PT-INR was also being monitored. We did her regular BP monitoring as well. See, it was a very difficult situation. She was a case of autoimmune hepatitis. It was a working diagnosis that we'd actually picked up in the second trimester. She was a lot of autoimmune problems in the background. She had low platelets, high rising liver functions. She was growth restricted. She did not have enough money. We did not want to deliver her. A lot of intense surveillance with the biomarker. So these were her reports, just to tell you that she was positive on the beta-2 glycoprotein antibody. She was positive on the ANA, the liver functions, as well as the TPO antibody. And this is how the tris kept normal. And at one point of time, when she reached close to about 35 weeks, the liver enzymes went really high, haywire, and we did not have too many literature reports to tell us how safe it was for us to carry beyond 34 weeks with rising liver enzymes. And the baby was already 1.8 kgs, and there was no satisfactory, great interval growth that was happening, and that was where we delivered. This is the patient and the team in our clinic. This is how her CTG looked, and the umbilical artery Doppler was still normal when we actually decided to deliver. So finally, we delivered her at around 35 weeks electively, because her liver enzymes had climbed up to more than 1,000, and the platelets had dropped to slightly less than 80. And the baby lived in the NICU for about a week for about level 2 stabilization. And she did not really have to spend too much, and the baby went home safely. So in this scenario, Dr. Srimati, because we are going to encounter several such situations which is going to confuse us with health and prompt us for an early delivery. So we have something like a delivery at 28 weeks versus a delivery at 35 weeks. So did biomarker actually help rule out atypical preeclampsia and endothelial dysfunction and help us to prolong pregnancy?
Thank you, Dr. Revati. So, I just wanted to bring out a few points. I would probably not have started her on LMWH, steroids, or HCQ for that matter, because the beta-2 glycoprotein I know was elevated, but she didn't have an antiphospholipid antibody syndrome. So I would probably have left her only on LDA. But anyway, that's a minor point, but that's what I would have done. I know a UAD was positive, but yes, LDA would probably be what I would have left her on. I'm not sure whether she did have a PLGF screening at the first trimester, because I do not know when this was done, but yes, that would have probably helped us also better stratify her risk, though the UAD was positive. Moving on, I know at 20 weeks, platelet was 98. I probably, imagine that a CBC at the first visit was probably normal. So at 98,000, as you rightly said, she's got lots of immunological issues. So whether she has developed secondary ITP, but I would have probably evaluated her at that point in time, because the PT was also going borderline. So I would have definitely, I know the abdominal scan was done to rule out hepatosplenomegaly. I would have probably wanted to do a peripheral smear LDH and to see what was happening at that point in time, and probably had a closer monitoring of the platelets and the liver functions. But as you said, she had gone off to Bihar. So when she came back at this point in time, we are having a dilemma. Yes, I agree, liver functions are abnormal, but the platelets are relatively stable. Because if you are thinking in terms of an atypical HELP, you would have probably had a galloping, sort of kind of a finding. But again, I would have looked at the peripheral smear and the LDH to see whether I do have any evidence of hemolysis. And I would have probably again not started on EDCA, because it doesn't fit in with the cholestasis picture, because the ALP is not very high compared to the ALT and the AST. And as you rightly said, it fits into an autoimmune hepatitis because anti-smooth muscle antibodies are positive. I would have had a discussion with the hepatologist and maybe thought about whether we should have hiked the steroids at that point in time. I would have probably not started on to begin with, but at least at this point in time, I would have definitely thought about, giving her a higher dose of steroids. because autoimmune hepatitis, though we would want to have a confirmation with liver biopsy in pregnancy, it's going to be very difficult for us to do. So I would have thought about whether, we could have done hiking up of the steroids at that point. Betamethasone, I may not have been very inclined to give it at that point in time, because I would want to rightly time it. But yes, I do not know about the exact extent of IUGR, so it's a bit difficult at this point in time. Yes, as you rightly said, I don't think we would have been too worried about an atypical PE, because if it was a PE, she would have probably galloped. But I think it gives us reassurance that we are not dealing with PE. So in that way, the negative predictive value has definitely helped us in convincing the patient and not have a preterm delivery. I would definitely agree, but I think we would have sort of with the clinical picture, with the evolution of what is happening, it was pretty certain that what we are dealing with was probably some autoimmune pathology. But yes, preeclampsia is also very common in these women, so definitely biomarkers does help us avoid an iatrogenic prematurity.
Thank you, Dr. Srimati. Let me tell you how this started, because she was actually started on steroids in the first trimester because she was ANA positive with raised inflammatory markers. And I did not tell you because the biomarkers was the point of discussion, and because she had a big subchorionic hemorrhage, her inflammatory markers, her CRP was as high as 36, her infection screen was negative, her diabetes was well controlled. So we had immunomodulated her with steroids. And when you're looking at the uterine artery Doppler, it's just like a working diagnosis, because we don't really know what is causing that uterine artery Doppler to be so high, because her endocrine parameters are absolutely normal, her inflammatory parameters are normal, and a suggested beta-2-glycoprotein antibody, though it does not really fit into the typical diagnosis of apnea. This was actually taken, with the clinician's consensus, a very precious pregnancy. And, and there have been some reports where low molecular weight heparin can definitely help reduce endothelial dysfunction and preeclampsia in women, when the uterine artery Doppler has been on the higher side. And she was at a time when we were not doing combined testing so rampantly, so we didn't do the combined test. And when she came back to us again after the Bihar episode, it was so difficult for us to actually digest that her liver enzymes were something like in 200s and 300s. And it is very easy for us to retrospectively call it autoimmune hepatitis, but at that point of time, having a woman who's just returned, we don't know whether it is infection, the platelets are dipping down, and then you have a little bit of growth restriction that is setting in. So we did start UDCA before sending the bile acid. In fact, the bile acid was normal, but we did not really, it was not completely normal. It was somewhere on the higher side of normal. I remember it was something around 17. So having a discussion with the gastroenterologist, we said we will not remove the supports. We will continue UDCA as well, upgrade the dose of the steroid, considering that we've made a diagnosis of autoimmune hepatitis. And that's how we actually increased the dose of prednisolone. And betamethasone was given only when her liver enzymes suddenly increased, a level of something like 200 to 300, went to something like a 687. So when we looked at literature reports of autoimmune hepatitis complicating pregnancy, we really didn't have, it was more of a diagnosis based on optimization of perinatal outcomes where the mother and the baby is safe. And they said something like the highest that we saw was something like more than 1,000. So we were thinking that we would probably have an accelerated rise in these liver enzymes, and that was what prompted us to give beta-2-glycoprotein, the betamethasone steroid when the liver enzymes soared up and there was growth restriction which was worsening. Yes, this is a big dilemma because these women are not going to give you history of what happened previously, and we need to salvage this pregnancy as much as we could. So with the biomarkers, at least we had that confidence that we were not dealing with a disease that's going to probably evolve overnight and cause problems both to the mother and the baby. And that particular value could help us reassure both the mother as well as the entire family that yes, we were doing the right thing. Because when you have the whole lot of people telling you that probably she's into help and she's into a lot of things and we are trying to continue the pregnancy, we need some kind of an objective evidence to prove that yes, she's still safe. So it was a difficult case, and I purposefully put this case because we as clinicians, we encounter such cases, but we seldom discuss in typical conferences because we are only talking about typical cases and not about atypical cases. So we really need to voice out and come out with these kind of clinical dilemmas and say how we handle it, so that this would give us a clue when we're probably handling this kind of a case the next time. Thank you so much for your insightful inputs, Dr. Srimati. And moving forward, I think I have this case. This was a case that we recruited for the robust study. This is to Dr. Nagaratnamma. I'm sure she's encountering these kinds of cases day in and day out in her hospital. She, with ART on the increase, she's going to come across so many elderly women who are going to be chronic hypertensive and metabolically very, very difficult to probably predict preeclampsia. So we had a 46-year-old. She was an IVF donor embryo conception. She was known case of chronic hypertension on tablet labetalol 100 milligrams BD in the first trimester. She was over diabetic on insulin and subclinical hypothyroid, and she was on thyroxine supplements. The abdominal scan was within normal limits at booking. I'm only telling you the salient features, which would probably help us, with respect to what we did with the biomarkers and how we identified the problems. So the abdominal scan was within normal limits at booking. The bloods were normal. The fundoscopy was normal. The ECG and echo was within normal limits. She was monitored with regular home BP as well as blood sugar monitoring with twice monthly antenatal visits. Her routine antenatal scans, which include her NT anomaly as well as fetal echo, was within normal limits. So she was chronic hypertensive. She was over diabetic. She was hypothyroid. She was elderly and IVF 10 conception. She was upgraded to tablet labetalol 100 milligrams TID at 24 weeks in view of slight fluctuation in BP. So we were looking at her BPs, and it used to be fluctuating between 140/90 to 150/100, and the idea was to keep it at around 130/85. And the patient was stable with normal bloods with no fetal growth restriction until then. Bilateral uterine artery Doppler mean PI was also normal. It was 1.18. It is also to tell you that it could be confusing to have a normal uterine artery PI, and suddenly this lady can slip into a complication like preeclampsia in the third trimester. At 28 weeks, the SPIT1 PLGF was found to be 133.5. This lady was counseled for the SPIT1 PLGF because I wanted to recruit her for my study, and according to that, we had to recruit them at 28 weeks, any chronic hypertensive women who were singleton and who agreed to participate. But incidentally, when we did her test, it was soaring high. It was 133.5, and she was stable, and she was, she was on two antihypertensives, and she was monitoring her sugars. The growth scan showed a lag of 9 days with expected fetal birth weight at around 900 grams. It was at around the 15th centile. Fetal Dopplers was within normal limits. She was counseled for prophylactic steroids because we told her that, see, your value was very high. You are prone to preeclampsia with severe features. Till then, the growth had been normal. There had been a slight change in the growth patterns. So it would be better, considering your age and other risk factors, to steroid you because there may be a possibility of an early delivery. Blood pressures were high. It was about 140/200 and 150/100 on that day on records over 2 days. So we interspersed capsule depin. We added a calcium channel blocker, 10 milligrams TID, along with the labetalol, with a regular dose of labetalol that was on. But the patient did not want any admission for monitoring. As part of the study protocol, we had to counsel them. We couldn't enforce them, but we had to counsel them to get admitted so that we could monitor their blood pressures. But she returned again within 12 hours with decreased fetal movements after 2 days of the previous. She said she had decreased fetal movements for about 12 hours. And this was after 2 days of the previous visit with abdominal pain. I still remember she came in the morning at around 7:30 to the OPD and said she had abdominal pain. She was not able to probably perceive fetal movements at all, and there was brownish discharge, and blood pressure was 160, 104. And the entire team was primed that this lady was somebody with a biomarker report of 133.5. So we were all, thinking about preeclampsia. So repeat bloods, we did the bloods. The LDH was 486 units per liter. The platelet counts was 1.6 lakhs per cubic millimeter. The urine albumin was 1 plus. Fetal Dopplers showed absent flow on the umbilical artery. We just put in the Dopplers because she's saying that she's not able to perceive fetal movements. And there was a little bit of abdominal pain. We were thinking in terms of abruption or something. And there was redistribution on the middle cerebral artery, and there was normal DV Doppler. Fetal movements were appreciated on scan, but they were sluggish. There was no obvious retroplacental hemorrhage, but scan definitely cannot identify retroplacental hemorrhage with normal LIGA. The CTG showed small spontaneous decelerations. At 28 weeks, having decelerations was definitely significant. Hence, counsel for a rescue dose of steroid So we said we will give you betamethasone 12 milligrams, and she was scheduled for an emergency Caesar. There was a strong suspicion of preeclampsia with severe features, may be complicated with abruption in view of a positive biomarker and changes on the lab, as well as the umbilical artery Doppler scan with decreased fetal movements. Intra-op, there was 200 ml of blood. This is still very scary. Every time I read this case, it gives me shivers. And noted after the delivery of the placenta was necrosed and calcified. Thankfully, I knew that she was positive on the biomarker. I immediately shifted her to a tertiary place and did the delivery. A baby boy was delivered with Apgars of 6 and 8 at 1 minute and 5 minutes. This was the last chance that she had to get pregnant. And thankfully, we got the baby out alive. It was an 875 grammer. The baby was anemic. It had lost some blood. So we had to transfuse 2 pack cells due to anemia after birth. The baby was stabilized for 9 weeks. The baby is about 4 years old and doing well, which is very, very reassuring. So we had probably delivered the baby before hypoxia had set in. So this is basically how the SPIT1 PLGF looked. The 133.5, the absent umbilical artery Doppler, and this mother with the team at Mirror Health. So the question is to Madam, Dr. Nagaratnama, did biomarkers help avoid IUFD with ART on the rise and elderly women with medical comorbidities getting pregnant? Are conventional protocols for monitoring and surveillance for preeclampsia really relevant? Can biomarkers make a difference in the above scenario? Did we make a difference to her by avoiding criticality and saving her baby?
Yeah. Hello. Revati, that was really well managed, but can you go back to the first slide on the case? Yeah. Here, see, she is already an elderly man, 46-year-old, DM conception with a history of chronic hypertension. And also she is diabetic, and there is a subclinical hypothyroidism. She has all the risk factors for PE. So I just want to know whether here, did the first trimester screening was done for PE?
No, ma'am. This was about 4 years ago. We didn't do the PLGF at that point of time. We did the uterine artery Doppler, which was within normal limits.
Okay. So, no, could that would have helped us to detect
she was already
early
on
onset
aspirin
PE or late onset PE? At least we would have known whether she's low risk for early onset PE or for late onset PE.
Yes,
so
that's a valid point. But this was at a time when we were not adding PLGF to the uterine artery Doppler.
Okay.
So we had actually added the uterine artery Doppler at that point.
No, like looking back retrospectively, could have helped us to detect? So that was she on aspirin because chronic hypertension with the PE positive, probably it would have come positive. And maybe if we have added aspirin at that point of time,
she's already
maybe
on
15
aspirin
weeks plus 6 days, probably this pregnancy we could have pulled on for some more days instead of, see, because at 24 weeks, then again at 28 weeks you're done because of the study you did a SPRIT and PLGF ratio. Otherwise we would have definitely missed this.
Absolutely.
So because of the study, otherwise we would have routinely would not have done, except for that we are monitoring the fetal growth restriction, and also we would have looked upon the Doppler findings and relied upon the doctor findings and then decided for delivery. Is it not? Absolutely. So probably this biomarker has really helped us, and it has given an alarm to us that, definitely like it could have definitely we have avoided the intrauterine fetal demise in this case, that too being a precious pregnancy. But only thing my concern was probably if we had done a first trimester screening and followed it up with a SPRIT PLGF ratio in the second trimester, probably we could have taken some interventions early and could have monitored much more closely, I feel.
Yes, ma'am, that's a valid point. We were not in the habit of doing the PLGF about 4 years ago routinely in the first trimester. And there have been a lot of women who come to us who are 20 weeks, 21 weeks, who missed the first trimester screening even now, where we are still resorting looking at the SPIT1 PLGF. And the best part of these women are they are already on aspirin and heparin because most of these patients are IVF conceptions and they are elderly.
Conception, yeah,
So
yeah,
in
yeah.
spite of this, if the uterine Doppler or if the first trimester screening was going to be just like the first case, if it was going to be positive, maybe we would have probably seen her every week or every 2 weeks.
Yeah, maybe close surveillance.
Yes,
But close
yes,
surveillance.
yes, madam. But if you were just going to, like how you said, if you're just going to rely only on the clinical parameters, would have definitely not caught this at, at 28 weeks, where she was going to probably evolve into abruption and probably have had an IUF.
Yeah, because she was included in their study. Maybe the 28 weeks.
I put this case because
ratio.
yes, madam, because these are real cases and this has happened. And though this case has happened about 4 years ago, there's a lot of learning that we can probably take home that the conventional monitoring may not really fit in these cases.
Yeah, yeah.
Now, with moving forward, we have this case where we have a 29-year-old primate. She is a known case of gestational diabetes on insulin. She was diagnosed gestational hypertension at 33 weeks, and she was started on labetalol 100 milligrams BD. This is to rule out the utility of the biomarker. She was counseled for the SBIT1 PLGF serial monitoring along with the conventional PT profiles that remain normal. No fetal growth restriction was scanned. Modified BPP done into every 2 weeks was good, and with interval growth measured every 3 weeks, which was not compromised. So she was a stable lady whose hypertension was diagnosed at around 33 weeks, and she was on labetalol. The SBIT1 PLGF, because she was a recruit into the study, we just wanted to see what was happening to her. And at 36 weeks, it was 18.45. And 34 weeks. And at 36 weeks, it was 26.2 because we were actually measuring her values serially, and she was screen negative. So this example is to just tell you what we did exactly at 37 weeks. So at 37 weeks, we did not deliver her, based on the fact that she was hypertensive and we had to induce and deliver her. But we told her, yes, we could probably have biweekly follow-ups for bloods and modified, BPPs with regular BP monitoring at home, which was all normal up to 39 weeks. So she reported to us every 2 weeks after 37 weeks. And she was induced and delivered at 39 weeks and 2 days when her Bishop score was good. And it was a 2.9 kg baby that had good UPGARs, and it was a full-term vaginal delivery with RMLE. So post-delivery, the BP normalized and she was discharged after 2 weeks, 2 days. So it was a very, very typical case of gestational hypertension. The biomarker had ruled out the possibility that there was pre-eclampsia anywhere, the late onset types even. So we had the courage to take this lady beyond 37 weeks, and we allowed vaginal delivery with a better Bishop score. So is there a need to deliver all hypertensive? This question is to Dr. Saravana Kumar. So is there a need to deliver all hypertensive women at 37 completed weeks? Can the biomarkers help identify those hypertensive women who are safe to be delivered beyond 39 weeks, optimizing induction of labor outcomes?
Yeah, actually, the traditional teaching is that we are supposed to deliver all the hypertensive patients at 37 weeks, especially pre-eclamptic patients. Maybe not with this gestational hypertension. But the thing what I see in this patient is she's had a very good control of her diabetes. She's already on insulin, but there's no fetal macrosomia. So that is another factor to be considered here to continue the pregnancy beyond 37 weeks. So, and once this split PIGF ratio is below the screen negative value, then probably we need not worry about because this got a very good negative predictive value. You need not worry about the complications which she may develop as she's progressing towards term. So that way, this was well managed with the diabetes as well as hypertension, and we probably gave her a vaginal delivery in spite of all these complications which she developed, just because of this biomarker values which we are able to find out.
Yes.
Can I come in, Dr. Revati?
Yes, Dr. Manisha.
Yeah. So I just wanted to add that whatever study that we have done recently, like in 300 women, we had done biomarkers at 28 weeks, 20 weeks, 28 weeks, and 34 weeks. And in all those, we have found that the predictability is not very good beyond 38 weeks. So the preeclampsia that developed after 38 weeks, they were not able to predict that. And I found the similar things in literature as well.
Absolutely.
So we must be a little cautious in now telling that it will not develop beyond 38 weeks when we are doing a the biomarkers, and especially like the later you do, as Dr. Sarosh also said, the later you do it, it was it will just tell you about 3-4 weeks. That's the main thing here. So if you're doing at 36 weeks, it will tell you till 38 only and not beyond that in most of the cases.
Absolutely, Dr. Manisha. We had taken this into our study protocol as well. So we'd stop monitoring the biomarkers beyond 36 weeks. In fact, the last recruit would probably stop. We would stop doing it at 36 weeks. Beyond 7 weeks, we did not know how to take these women. So we started intensifying surveillance. That's why we called them twice weekly. And we did all the parameters, tested all the parameters. They had fully consented that they wanted to continue pregnancy because there was no other issues that was complicating. We intensified clinical surveillance. We did not rely on the biomarkers and took them to 39 weeks. So the idea is, though the biomarkers did not support you beyond 37 weeks, maybe in these screen negative women, because I can show you some of my slides in the study where a woman who's screen negative continues to remain screen negative even
you had
7 weeks. So in that situation, if you're going to intensify clinical surveillance and you know for sure that she's not going to probably develop preeclampsia, you can optimize the timing of delivery and take them to 38, 39 weeks safely is what we were trying to indicate. Definitely the take-home message is we cannot rely on the biomarker beyond 37 weeks. We have to rely on clinical surveillance, but it's not mandatory, I feel, that we have to be delivering every woman at 37 weeks.
Yes, true.
Because that could probably, endanger the fetal outcomes. There could be a little bit of exaggerated respiratory distress, especially, with gestational diabetes. And if it can allow, we can probably go ahead safely. Thank you so much for the input, Dr. Manisha. So yes, the biomarkers helped us to get beyond 37 weeks safely and allow vaginal delivery with better Bishop score. And thank you so much for this panel. We had some enlightening inputs by Dr. Srimati, Dr. Nagratna, Dr. Saravana Kumar, Dr. Manisha. They are all from different setups. We've had people from a corporate setup, a medical college, different places of India. So this has definitely added a lot of value to our study. And we were talking about cases that happened in our country as part of the robust study. So it was really very, very interesting. And as far as the future implications of biomarkers, if Dr. Sarosh is around, because this is something that she is doing in the West, and she could probably enlighten us as to what is happening with the biomarkers in the West. Is Dr. Sarosh around?
No, Dr. Reddy.
Yeah, I think it was very late, and so she said she would join in as much as possible. So if you're looking at the future implications of biomarkers, yes, we are looking at first trimester combined screening together with surveillance with the biomarkers to map preeclampsia, like how all of them have reiterated as the need of the hour. Use of androgenic biomarkers as a tool to identify patients that require tertiary care, very, very important. So you can identify who has to go to tertiary care to avoid criticality. Ongoing research, yes, we have preeclampsia prediction with mid-trimester one-step test. If somebody has missed screening in the first trimester, why not screen them at 24 to 26 weeks and find out whether they are at risk for early preeclampsia. Preeclampsia treatment to reverse the androgenic imbalance. There is a lot of work that's going on where they can scavenge the SPIT1 and try to promote prolonged pregnancy to some extent. Neutralizing antibodies against the anti-androgenic proteins like the statins have also been experimented. So all this is happening, and I'm sure with the ISSHP World Congress that's going to happen in Bangalore, we're going to discuss all this with the real investigators and know more and to probably know how we can extrapolate it to our population. So thank you so much for this enlightening panel and for all the inputs, which has definitely added value to each and every clinician who's watching this panel. So with this, I move on to Dr. Anu, who could probably take it forward with the next capsule. Thank you.
Thank you, Dr. Revati, and thank you everybody on the panel, which gives us an insight into how biomarkers can help us in our clinical practice, into our day-to-day clinical practice.
Dr. Anu, are you calling in Dr. Chaitra? I think Sir has joined. Dr. Prakash Mehta, Sir has joined. Sir, can you please give a few words?
Sorry, first of all, I apologize for joining late because, it's quite late. Right now, I'm in Vancouver and it's quite late over here. But anyway, I was there for quite a bit of the panel. I'm sure we have all got very good messages from it. But one thing we should never forget is that pre-eclampsia is not a single disease. It's a syndrome. The moment we start thinking in those terms, I'm sure our management of pre-eclampsia would be much, much better. The second important thing is even if we consider, let us say that pre-eclampsia has got a common etiology, even then the early pre-eclampsia versus late pre-eclampsia have got their own issues. Now, early pre-eclampsia is something which we can definitely diagnose well, both by uterine artery Dopplers as well as biomarkers. But any of the late preeclampsias are very, very difficult to identify. The good point about this is that the late preeclampsias, the decision taking is very simple. If I have to decide on a 27-weeker, 28-weeker, because that's the situation more often I'm involved with, at 27, 28 weeks, you literally have to rack your brains to decide whether I have to deliver this patient or no. At 38 weeks, I don't think it becomes such a big issue. If I have even even if I err on the wrong side of delivering a patient, nothing happens. Everything goes well. So, and biomarkers definitely help us very well in identification of early onset preeclampsia. Unfortunately, I missed the first part, but I don't know whether the complications of preeclampsia, including accidental hemorrhage and renal failure, these two complications especially can be very well identified by biomarkers if we are doing it. I've had any number of patients where the patient has just shown one reading of 140/90. And of course, in my setup, I do more often glycosylated fibronectin as compared to a split PLGF, but both work equally well. And when if the test is abnormal, we start intensively monitoring the patient. And of course, this is not a published data, but at least about 20% of them who had abnormal results on biomarker landed up with accidental hemorrhage. So at least it gives us a clue. It may not tell us directly that, yes, you need to deliver at 27 weeks. I've done the test. Biomarkers are abnormal. It doesn't tell me immediately that I have to deliver the patient, but it definitely tells me that I have to keep my all antenna up. I have to monitor this patient, both the fetus as well as the mother, in a very intensive manner. With this, I think Dr. Anu is in. Dr. Anu, could you take over, please?
Yes, sir. Sorry, there's little trouble with my
technology is exactly like pre-eclampsia. Things don't work when you want them to work.
Yes, sir. Same story here. Now I would like to welcome Dr. Chaitra, Masters, to talk a few words about making of PENAI. PENAI is Pre-Eclampsia Education of the Nation, India. There has been lots of work that has gone into this educative program for doctors who are OB-GYNs or otherwise, doctors who are working in the periphery, doctors working in the government setup. Dr. Chaitra, over to you for talking about the making of PENAI.
Thank you, Dr. Anu. I'll just share my screen. Am I able to share my screen? Is it visible?
Yes.
Yes, Dr. Chaitra.
Thank you. So a very warm good afternoon to all of you. And it's indeed a pleasure to share the journey that we all have been through in the past few months and years, and what is going forward and is building up into a very strong project, PENAI. PENAI, as you all are knowing, is Pre-Eclampsia Education of the Nation, India. And this is a certification course for practicing obstetricians and gynecologists. And we have developed teaching modules with taking into consideration the latest updates on hypertensive disorders in pregnancy. And the special emphasis is on preeclampsia. This is basically a collaborative project which started off with brainstorming by two major associations, the Society of Maternal Fetal Medicine India and the ISSHP. All of you are very, very familiar with the three pillars of PENI, and it gives me immense pleasure to talk about them every time. Our Indian co-chairs are Dr. Prakash Mehta. He's the president of SMFMI, and he's the chief Department of Maternal Fetal Medicine, Bhagwan Mahavir Jain Hospital, Bangalore. And shouldering the responsibility very ably and guiding all of us every time is Dr. Revati. She's the secretary of SMFMI, and she's the chief consultant and managing director of Mirror Health, Bangalore. Always supporting us, providing us the global perspectives is our global co-chair, Dr. Saroj Rana. She's the section chief maternal fetal medicine. She's at the University of Chicago, USA. She is the co-chair of the Global Health Committee at ISSHP, and she is our international advisor for the SMFMI. Now, the first question, the thing that we addressed was, why do we need PENI? Because as we all know, and you've already listened to the panel and several other panels that we've been doing, there is a lot of variation in the consensus regarding the definitions, the management, the guidelines, and especially the postgraduate students tend to get confused regarding what should be the ideal definition, what should be the classification, and of course, how do we manage the various types of hypertensive disorders of pregnancy. And that's what made us to put all the information regarding pre-eclampsia in a nutshell and provide it to you so that there is a lot of clarity and probably there is a common consensus in our country in trying to manage pre-eclampsia and its variants. The second issue is no longer do we hold good the standard definitions like blood pressure of 140/90 and urine albumin of 1+. Every time there is so much of atypical presentation. Proteinuria may be present, may be absent. Hypertension may be present, may be absent. And because there are so many dilemmas, discussing every case in detail, having different case scenarios really helps us to identify all the cases and not miss out on any patient with preeclampsia, be it typical or atypical. Again, despite having the knowledge, there could be several issues in implementation in the urban and rural settings. Also, there could be a lot of challenges that we face in extrapolating the international guidelines. And that is why we all felt it is very important to have some protocols relevant to the Indian setup. So whether it is a practitioner in the urban setup, whether it is a nurse in the rural setup, all of them who are managing preeclampsia in some way or the other should have a complete knowledge of preeclampsia and its variants. And that's why we came up with the idea of PENI. How did we go about designing the modules? It was a jigsaw puzzle that we put together with a lot of effort. So it was a comprehensive, it is supposed to be a comprehensive end-to-end collaborative evidence-based course. The collaborative efforts with special emphasis on translational research. The course is basically very, very clinician friendly. So lots of case discussions, lots of case scenarios, and lots of opportunity to interact with the mentors so that doubts at any point could be cleared. And also definitions, classification, management dilemmas, evidence-based protocol, everything was put together comprehensively to help us understand the disease. So the concept actually started in August 2020, and how we went about building up this project by establishing the collaboration first between SMFMI and the International Society ISSHP. The Roche Diagnostics India Private Limited was the major educational grant for the pilot project, which we are doing now. The project specifics were designed. We liaised with clinicians from all across the country and the globe. Whoever was eminent in the field of hypertension and pregnancy, the inputs were taken from all of them, and all of them have been involved in designing our modules and our speakers in most of our modules. Our staff at SMFMI office have been constantly working for all the efforts that we are doing in this direction in terms of talking to the delegates or designing the programs. So we have recruited very good staff at the SMFMI office. Medinet has been our major support, and we have liaised with Medinet for the content compilation, recording, and hosting of all the programs, including this one. And we worked specifically on all the course propagation strategies, like how do we reach out to each and every person and in every nook and corner of India so that people know about this course and can make use of this course. It was a very strategic moment for us when we launched our project online on the 21st of May 2021 on the World Pre-Eclampsia Day. And from then on, there's been no looking back. The course began on July 2021. The registration was all mediated through Medinet. And the fee structure of this course is very nominal because we want as many people to be able to access the course and benefit from it. Who are our supports? As we already said, they've always been with us. Roche India Diagnostics Private Limited, who have been the financial pillar for the pilot project. Our very able staff of SMFMI office, Mr. Shrikant and Mr. Rajagopal, who have been constantly with the IT support, and Dr. Meghna Srinath, who's the coordinator for the concept of this course. Medinet has been our partner, the knowledge and hosting partner, and they take care of all the registrations, the course propagation, and the course specifics. Lots of work, lots of meetings, and everything has been so fruitful that we're really happy. Everybody has put in a lot of effort, and that's what we're seeing today as the course is going very successfully throughout the country. Lots of brainstorming sessions. We had several concept builders, and we had about 10 PPI meetings, and there was extensive discussion. There was what should be included, what should be given more emphasis, so that the clinicians can benefit out of it. And the Penai core team and the concept builders all sat together, designed the 6 modules that we have. Again, all the content was peer reviewed, and before we finalized, we had several meetings and put the content together and decided that these would be the modules that we are going to have. We are also in the process of designing modules specifically for the BBMP workers and the Ayush workers as well, so that they can also benefit from this course, and that process is also happening full speed. I would like to just give our heartfelt gratitude to all our SMFMI office team, because they have been constantly coordinating the meetings, the PPI meetings, the one-to-one meetings with the speakers, the Medinet people, the Indian co-chairs, the international faculty. All the back-end work has been done very efficiently by the office team of Mr. Shrikant, Mr. Rajagopal, and Dr. Meghna. The collation of the MOUs and the documents from the faculty were all done on time. The office staff also helped in structuring the content, brochure designing, and doing all the plagiarism checks, which is a major issue. The creation of Penai helpline has been made because whatever queries are there, they're addressed from time to time, and the delegates don't have any difficulty in connecting with either the mentors or the office staff. Emails are there, collaborative efforts to link the delegates and the course faculty throughout the country and the globe has been made through emails and WhatsApp. We, of course, started off, or we are through the pilot project now. And the reason why we did start off with the pilot project is because we wanted to concentrate on a small group of registrants so that the certification process is easy. Once we begin and once we know what could be the issues that need to be addressed or any modifications, then we could move on to the bigger perspective. We also very importantly wanted to gather feedback from the delegates and the faculty so that as we progress, we want the course to provide the most important content and the most relevant content. And also to add value to the project beyond the pilot with insights that we procured during the pilot project implementation. And as you all know, the pilot project encompasses 4 courses, and there are 6 modules in each course, including the assessment module. And each pilot we intend, and we have about 50 to 75 delegates. What's the future? The future is big as we all are envisaging it, and we need all your support to go big. So to navigate beyond the pilot, to reach out to all the practicing clinicians across the country and even beyond through our collaborations, periodic module updates would be made to make the course relevant to day-to-day practice. We would like to empower the clinicians with the latest evidence-based guidelines and research on preeclampsia, and that's why we believe in updating our modules as and when the progress happens. The whole idea is we need to reduce the maternal and perinatal morbidity and mortality due to preeclampsia. We would reach out to global organizations also, which we have been doing for their support in this venture. And also at every juncture, we would like to support whatever research is going on in preeclampsia in order to improve the quality of care in our country. These are all the archives that you could go through, which are available on YouTube, the programs that we have done so far, and you could benefit from the various panels and other discussions that are there on YouTube. I thank you all for your support for Penai, and please be with us and spread the message across to as many of your friends and colleagues so that everyone could benefit from this course. Thank you.
Thank you, Chaitra, for that detailed elaboration of what happened with Penai. The idea of Penai was basically the idea of identifying preeclampsia and its problems was born almost about, I would say, 1.5 to 2 decades ago, when all the young, bright consultants of today were my students, and we would sit together and discuss what is preeclampsia, how to handle it, what to do, why there is a confusion about management of preeclampsia. And then later on, as time evolved, everybody got together. We came in with the Society for Maternal Fetal Medicine. Of course, we had a lot of ups, downs, a lot of hard work, a lot of tears, a lot of laughter, everything. But ultimately, we decided that unless we have a proper course and unless there is a certification in place, our management will not change. Now, again, let me tell you from my own experience, because I get referrals for preeclampsia from all over South India. The management, sometimes when you look at it, you feel, how did this kind of management occur? Obviously, we are missing quite a few things when we are managing the preeclamptic patients. And so that is why we wanted this program to go ahead. Initially, we thought people may accept, people may not accept. We were a little hesitant, started with a few small baby steps. And I'm very happy that now we have reached a stage when our program is welcomed all over India, and we are also going abroad to various countries in the world. And the best part of this was that the ISHIP, the International Society for Study of Hypertension in Pregnancy, was so impressed with our program that they kind of literally wanted us to hold the ISHIP 2023 conference in India and in Bangalore. And they wanted the Society for Maternal Fetal Medicine to take the major role in it. I mean, that was a real kind of faith that they deposed in us, because South Asia, or rather the complete Asia except for Japan, has never had an ISHIP conference. It is a prerogative of the Western countries or the westernized countries like Japan who have been holding this conference. We are still a developing nation, and they decided to have the faith in SMFMI, the Penai, and they wanted us to hold the society's meeting over here. And I take this opportunity to welcome you all to that conference in 2023, because who's who in the world in the field of hypertension in pregnancy is going to be there. The names that you have studied in the textbooks, or the names that you have, when you have been reading a journal, you come across those names, and all those people will be present in this conference. So, and we are also open to take as much help from everybody, whoever can give us help in whatever way they can. We are willing to welcome that, and we hope that we have a wonderful 2023 conference. We have decided that to keep up the scientific protocol in a proper way, we have decided that we will not allow the audience strength to exceed 1,000. So we have to keep our registrations limited to 1,000. And let me remind you that in any of the ISHIP conference, at least 650 delegates are from various countries in the world. And India has been generally contributing 5 to 7 delegates to the ISHIP conferences. Unfortunately, that is the truth. And that means we have only about 350 to 400 seats available for India. Kindly spread this message across so that the moment the registrations open up, we'll have to go on first come, first serve basis. So please ensure that you register early. Okay, the second important thing that I have to make an announcement, I don't know if Revati has already made that announcement, but that the book on hypertension in pregnancy, again, which is going to be a multinational effort. We have people from all across the globe contributing to it. Again, who's who in the field of hypertension will be authors for that book. Apart from, we wanted an Indian perspective to everything. So major, quite a few chapters in that book will be written by the Indian authors. And we have taken special care to ensure that anybody who contributes a chapter should have an experience in hypertension. It's not just something theoretical that I read 20 books and make a chapter. No, unless you have your own practice, own experience, then only we are going to invite them as an author. This book will be released during the iShip conference of 2023. For this book, again, apart from Dr. Revati and myself, we have Dr. Kenneth Shen, who is the president of the International Society for Obstetric Medicine, and Dr. Ganeshan, who is the president of the Obstetric Medicine Society of Malaysia, as editors. And we are going to have mainly contributors from USA, Canada, Hong Kong, Japan, South Africa, and of course, Malaysia and Singapore, apart from India. I'm sure this book would possibly meet the highest standards that are required for a book in hypertension. So I would definitely welcome you to be part of that conference when this book is going to be released. So again, I end this talk by thanking all my former students who are now my colleagues, who are doing great work in the field of hypertension and who are doing great work in education of the community, both medical as well as general public. I mean, I've been blessed, I should say, with this wonderful team. Thank you, team, very much. And I'm sure we'll come out with a wonderful conference and a wonderful book in the next 1 year.
Thank you so much, sir. Thank you for being the guiding light, actually. With that, I would now like to invite Dr. Asha Nirvi. Madam is a senior OB-GYN who has taken the PENI course to tell us about how she felt about taking the course and going forward with it.
Good morning. Am I audible?
Yes.
Yeah.
Yes, ma'am. You're very much audible.
Yeah. Good morning, Dr. Prakash Mehta. Good morning, Dr. Revati. Because these are the two people I just made me join this course, and the course gave me a complete knowledge of pre-eclampsia, because we have a huge load of pre-eclampsia. And being in Dharwad, I'm the head of the department of SDM Medical College. Every day we get a case of pre-eclampsia, whether it's a winter, rainy season. We have a variety of them, especially the early onset. So that made me that I should know more about this disease, and I felt very happy that I got to know a lot of protocols about this pre-eclampsia, and also I got to know that I was missing something always while taking care of my patient. And believe me that all the members of SMFs, they are very interactive. They make you do the course. Like if you don't do, they are behind you, and they are very kind and very nice. And I just want to express that I would love to do a lot of research in this field, sir, Mehta sir and Dr. Revati. So can you just guide us, because we have a lot of cases, and definitely this biomarkers is, I don't know, we are not able to, still it will take long time for us to pressurize our management and also to patient get it done. But I just love this biomarkers. We should get it done actually to the patient, because I feel they're very useful. And I hope in future that you will guide us, and again will update us, and you will involve us in all the research. I think that's all I would love to say. And this is an excellent course. I recommend it to everyone. Thank you, Dr. Revati, once again. She was very kind when she came to Hubli, and I saw a lot of patience she has. Really, God bless you with all good things. Thank you, Mehta sir, once again for starting this course, and I'm glad that I'm a member of this SMFC. Thank you.
Thank you, Dr. Asha. During the iShip conference in 2023,
yes, sir.
We are going to have 3 full days of free papers and posters.
Yes, sir.
And as in India, we do a lot of work. I'm sure you would have done, handled more pre-eclampsias than possibly some of the Western authors.
Yes, sir.
But
yes,
we do not publish.
Yes,
we
sir,
do not keep our records and we do not publish.
Yes.
So this is an opportunity for all of us to buck up and make sure that we present at least one paper in that iShip conference.
iShip, I will.
So that, not only just you, madam, but even your postgraduates, the youngsters,
Yes,
because
yes,
ultimately when the youngsters start presenting, the mindset will change.
Yes,
it won't be only a practice related.
Yes.
Unfortunately, in government hospitals where there is a lot of work, the workload is so heavy that academics, research takes a little of a backseat. I think it's time we change this mentality, and people like you are in the right position to ensure that the youngsters start changing their mentality.
Yes.
I request anybody who's listening to this course, all our delegates, that please buck up. You have exact 1 more year to get ready for the paper presentation.
Yes.
Each of the papers that are going to be presented in the conference will be going through 2 foreign and 2 Indian reviewers. Only if it is found to be of acceptable standard, then only it's going to be published. So it will give you a good insight into how to write a paper. Again, in international journals, most of the Indian authors' articles, come back with all kinds of remarks. And it's the time we change that.
Yes.
So everybody, please buck up. 1 year we have got. 1 year is a long time. You can definitely make a research paper. With the amount of clinical caseload we have, it is not difficult.
Yes, sir.
So thank you, Dr. Asha, for taking the course. And thank you for your good inputs, because when we were deciding at what score to pass the candidates, we discussed starting from 60% to 80%.
Yes.
And then ultimately we thought 75% was the right cutoff level to know that, okay, this candidate has learned at least that much of pre-eclampsia. And I'm glad that many people have managed to get 75% even in first attempt. And I think that's really creditable. And God bless all of you.
Yes, sir. Thank you,
Sir,
sir.
before we move on to the next delegate, Dr. Asha Neravi wanted to coordinate an on-site program for Penai at Hubli Dharwad.
Yes,
so
sir.
she would be interested to get about 25 to 30 participants to be, certified for Penai on a single day, sir. So we should probably start
definitely. Because we want to try to reach every medical institution. As a matter of fact, even for the corporation doctors, we are coming out with a shorter course, because they said they cannot afford to spend for this so many modules. So we are trying to give an abridged version to them, so that at least some basic knowledge comes in. It may not be that of course they will not get a full certificate like what our Penai delegates are getting, but we thought at least something is better than nothing. So let us do a small work at least, and this possibly we are going to spread across all over India to various corporation setups, so that our management of pre-eclampsia becomes very good. Now, all of us, I'm sure, have learned with trials and error of how to manage pre-eclampsia. And if we put our experience together, possibly the next generation of women, I would say, will be saved from, what I shouldn't use the word mismanagement, but ultimately it lands down to mismanagement of pre-eclampsia. Yes, Dr. Revati.
Yes, thank you, Dr. Revati, Dr. Asha, and Dr. Prakash Mehta. Now I would like to call upon Dr. Veena Dotam, who is also another candidate who has taken up the Penai studies, and she's gone through the entire course and finished it. Dr. Veena, hi. Would you like to share your experience with us?
Yeah, thank you so much. Thank you for inviting me to this platform to share my experience. I must say this course, after doing this, the full course, I can appreciate how much of hard work and how much of, the reading and research and minds have been put in to compile such a vast topic into, like seven modules. So I am extremely thankful to all the, people who are behind creating this, Pen-I course. And I feel, it was like, it's very useful for the obstetricians like me who have, like done their theoretical reading 20 years ago. I did my MD 20 years ago. And it was like complete de-learning and learning about preeclampsia again, because so many things have changed recently in the last 5 years about preeclampsia. It's an excellent platform for creating our own departmental protocols. Like as previous speakers have said, we need to ensure the uniformity in managing preeclampsia. The whole thinking about, preeclampsia being blood pressure of above 140 by 90 with proteinuria, that has changed. The flow of the course was so good, right from starting the pathogenesis to, the clinical features, management not only in the hospital setting but also for the clinicians who are working in the periphery. So that was the part I really liked about the course. And in the case discussions, they were really eye openers. One of the in one of the case where women with just slight blood pressure, above the normal range, she deteriorates so quickly. So I think it is important to, for not only just the obstetricians, but also the general practitioners or doctors working in any field to have knowledge of preeclampsia, because women, might be presenting to them with some other non-specific features like epigastric pain or some visual problems presenting to ophthalmologists. So everyone should have some basic knowledge of preeclampsia. So you are doing a great job in, trying to access or reach all the doctors as much as possible to all different parts of India to teach the nation about the preeclampsia. So well done.
Dr. Veena, can you please introduce yourself? And I think she is all set for the live session, sir. She has also finished the assessment, so she will be in the next graduation ceremony.
Oh, great.
Dr. Veena Dontham. I'm working as a gynecologist in Women's Center Hospital in Coimbatore. I have recently moved to India. Actually, I was working in UK for last 18 years. Before that, I was working in Delhi for 5 years. Done my MD from Delhi and then did registrar job in Delhi. So about 6 months ago, I have moved to India. So currently practicing in Obs and Gynae.
Okay. I think the most important lesson from these two speakers, two of our delegates who have taken the course, is that at their age and at their experience, if they found the course useful, I think our youngsters should, take this course up in droves.
Yeah, definitely. It's highly recommended for everyone, for every medical student, anyone practicing in medicine, Ayush doctors, anyone who deals with the pregnant women or even non-pregnant women, because women might be planning pregnancy in future who had previous history of preeclampsia. So giving them the knowledge how we can prevent the mishap, which might have happened in the last pregnancy. So it's actually, it's extremely, extremely useful, because many women in India, unless they are in, going to corporate hospitals, they don't even go for booking until it is, like 24 weeks. And by that time, that window of opportunity is lost to start the aspirin and to, screen them for high risk factors.
Yeah, through the Pre-Eclampsia Foundation, which looks after the Pre-Eclampsia education of general community across the world. We are soon going to have a tie-up with them also, because I'm sure the commonest thing that you would have come across is either the mother-in-law or the neighboring lady tells the patient that, oh, a little bit of swelling is absolutely all right. So what? Little blood pressure will increase. You have got 2 lives in you, and that's why your blood pressure might increase a little bit. Don't worry about it, doctor. If you go now, doctor will do cesarean and things like that.
Yeah, that's true.
So we are going to tackle that part of the, I should say, a weak link in the actual management of pre-eclampsia, along with the Pre-Eclampsia Foundation. And we are in the iShip conference also. We are going to have a special session from the Pre-Eclampsia Foundation And we are just trying to work out if we can even have a public forum kind of a thing, so that this knowledge is spread across.
Yeah, sure. Yeah. Thank you, sir. And like as the previous delegate said, I would like to offer my help in any way, in helping the community, pregnant women. So if any opportunity comes for me to present or, help you with teaching sessions, I'll be more than happy to help you out.
Thank you. We are very happy with this kind of responses, and I'm sure we'll utilize your services.
Okay. Thank you, sir.
Thank you, Dr. Asha and Dr. Veena, for sharing with us your experience with Penai project, and happy that you've loved it the way that you've loved it. Next, I call upon Dr. Sunita Mahesh. Madam is our in charge for spreading the wings of SFMI. She is our person in charge for new chapter formations. Today, Madam will be taking us through the new members of the family joined in all the way from Tamil Nadu. Madam, the stage is yours now.
Thank you very much, Dr. Anu. So, namaste one and all. It gives me immense pleasure in inviting all of you to the inauguration of the launch of the Salem chapter of SMFMI today. Actually, it gives me great pleasure in knowing that many doctors are interested to be a part of our society. And I'm sure that in the coming days, we will have many such chapters added to the SMFMI society. To do the honors, I invite our dignitaries, our chief mentor, Dr. Prakash Mehta sir, our international mentor and advisor, Dr. Sarosh Rana, who has taken keen interest in academic activities of our society, and also all our society members and the esteemed faculty who took time to participate in this interesting virtual learning series on pre-eclampsia. We believe in the fact that knowledge is power in eliminating ignorance. We will begin with the inauguration program with lighting of the lamp along with the invocation song to seek the blessing of Goddess Saraswati to sail through this journey of knowledge sharing and in collaboration process of chapter formation all across the country.
Sarvaswati Namostute Sharade Vidyavrade 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 Sarvaswati
Thank you, Shrikant, for sharing the video. And it's always awesome to hear to our Aprameya, son of Dr. Revati, to do the invocation for us. I now request our President, Dr. Prakash Mehta, to address the delegates and the dignitaries about our society and to declare the launch of Salem chapter of SMFMI. Over to you, sir. Over to you.
Thank you, Dr. Sunita. As I've said, all my ex-students and now my colleagues are all very hardworking. You have already seen how Revati works. And now we have Anu and Dr. Sunita who work quietly and ensure that the society really spreads along. We started with 10 members. We didn't even start as a society initially. We just started as an initiative and started having some scientific programs where we would have 10 people and 15 people, but who are highly interested and, interactive. Over a period of 1 year, then we thought that, no, now we should move into the formation of a society because we do not have a society in India which is concentrating only on maternal fetal medicine. My thoughts have always been that when you are in practice, I cannot do a laparoscopic hysterectomy and then come back and look at eclampsia and then again go back and do a DNC and things like that. Unless we concentrate on our patients with not just pre-eclampsia, because society maternal fetal medicine deals with all high-risk conditions. And whether it is a diabetic patient, whether it is a anemic patient, whether it's an immunologically compromised patient, they need our full care and they need our full knowledge. So in every part of it, we need the knowledge. Now, today's session is a part of pre-eclampsia teaching programs. Simultaneously, we also have programs for the other high-risk conditions, starting from diabetes to thyroid to, we already finished on autoimmune. We already finished on infections. We have finished on vaccinations. And we are going to have these kind of programs running parallelly along with the pre-eclampsia program. Then once we got together, we decided we'll have a Society for Maternal Fetal Medicine. From the past experience, I was very sure that if you do anything, it has to be absolutely registered and legal. So we went ahead and with the small group, we registered the society and we started working. Over a period of time, we found that our numbers of delegates went on increasing over a period of time. And we had a lot more, delegates interested. We had a lot more people coming forward and telling us that, oh, this is something that we have not even heard of, and this kind of interactive sessions we are very happy with. So then I gave Sunita the task of starting the chapters across the various countries. This, mind you, this was before the iShip conference was offered to us. Now, once the iShip conference is offered to us and we're going to do the iShip conference, of course, the momentum is going to increase. But even before that, I'm very happy to state that we have a whole list of societies, chapters going to be formed in the next few months as we move along. We started with Mysore, which showed the first interest. And after that, we had a critical care conference in Salem as a part of UFOXY. And of course, I couldn't go personally, unfortunately, but Sunita had gone over there and she had a nice interaction with the Salem people. And today I'm very happy to state that we are going to inaugurate the launch of Salem Society today. Dr. Sarvana Kumar is here and he has been instrumental in starting this Salem Society. We are looking forward next to, maybe Aligarh, then Lucknow, then Delhi, then maybe Pondicherry, then Chennai, and so on.
Sir, also add Dr. Asha's Dharwad program.
Absolutely. Dr. Asha's Hubli Dharwad Society.
Yes, yes, sir.
Chapter of the Hubli Dharwad we are going to have. So we are going to progress slow and steady, and I'm hoping that by the time the iShip conference comes, we have at least 50 chapters across India. And each of the chapters, we have made certain rules and regulations that they have to conduct certain amount of scientific programs. It is all there, put up in the constitution and bylaws. The aim is academics, that is all. We are not interested in anything else except that our pregnant women, especially our high-risk pregnant women, are treated very well. And there should be no, there should not be, none of us want to do a deliberate error, but inadvertent errors are very common. So we should try our best to avoid these inadvertent errors, and the best way to do is to start teaching people. Again, from my experience, what I've seen is that there is the same set of people who generally keep on attending all CMEs. And I'm very happy to state that SMFMI has broken that mold, and we are trying to reach at, every kind of obstetrician across the country, maybe medical college professors or postgraduates or corporate hospital doctors, absolute private practitioners, nursing home doctors. and going all the way down to even MBBS doctors and Ayush doctors. And of course, we should never forget the backbone of our health practice, the nurses. So we are trying to reach at every level to improve the high risk management of our Indian women. And we are happy to state that, of course, it is very initial. I can't lift my collar and say, no, we have done it. No, we are just starting, and but what I was happy to note is that the spread has been beyond our expectations. The response from the obstetricians across the country has been beyond expectations. And I hope this kind of tempo continues and we all join together, have again a wonderful conference, and have a good care for our high-risk pregnant women. I've already got my project ready for my younger team members. Once the iShip conference and the book comes out, that we start having absolute guidelines and the protocols for our country for high-risk situation. But we are waiting for the conference to get over and the book to be released before we go into the next step. So everybody please get up for that. And by that time, we'll have enough members like Dr. Saravana Kumar, very enthusiastic, very learned, I should say. Such kind of people more and more join us. We have Dr. Sushma Dev from Mysore. Again, I would say for me, she was a discovery. Such a brilliant academician, such a outgoing person was there in Mysore. Until we went to Mysore, I didn't even have that idea. And today we find Dr. Sushma Dev doing a great work. Dr. Saravana Kumar has already proved himself in the conference of Salem, so I'm sure we have no doubts about this thing. And same way, the other societies across the India, they're all coming forward. We have been very clear that we are existing only for academics, not for politics, not for self-fame, not for me or mine. Everything should be for us and our patients. So welcome, Dr. Saravana Kumar, and I'm sure you'll do a wonderful program in your place. Thank you very much for joining us.
Please declare the Salem chapter open.
Yeah. So I hereby declare the chapter of SMFMI of Salem open and welcome.
Thank you, sir. I now request Dr. Saravana Kumar to share his views and his vision about being a pioneer in helping to launch the Salem chapter. Sir, please.
Thank you, sir. And thank you, Dr. Sunita and Dr. Revathi. In fact, when I look upon finding some study materials or some doubts in my practice or for teaching, I always come across things from US or UK or Canada telling about every high-risk situation being dealt with by SMFM, that is a Society for Maternal Fetal Medicine, either Pre-Eclampsia or Preterm labor, diabetes. Everywhere they are teaching, they are a society, and they have fellows who are doing a very great job. But it has not been instrumental in our country. I don't know why it took such a long time for us to gather together and start a society of this nature. So that's very, very important, and we have to take it forward. And I'm very happy that we are part of this society in its earlier inception itself. So I want to share my vision and mission for our society and overall for the SMFM in India. I'll share my screen. So I'm happy to be part of this SMFMI Salem chapter and initiating this. So our vision and mission is to spread the knowledge about SMFMI, because this has to be done throughout India, so that we have a uniform practicing protocols. This is among our society members, and encourage OXOS members, our society members who are practicing high-risk obstetrics, to become life members, because once they become the life members and then they start doing this high-risk obstetrics, that becomes a streamlined one, so that we all can have a uniform thing. And then develop uniform management protocols for obstetrician in the field of SMFMI and distribute to the Salem Society members about each and everything what we practice. conduct regular CMEs and seminars to update ourselves and train members in managing high-risk obstetric, because we see, as Madam told, that we see a lot of the patients coming from peripheries. So managed by MBBS doctors, managed by PhD doctors, and then when they land up with us with a lot of complications, so somehow those things have to be curtailed, and those patients have to be, we have to teach doctors so that they take up things which are supposed to be done in a proper way, and develop a group of dedicated SFM members who can take charge of patients who need expert care and management. And introduce our society members to PENAI program. This we have already done, and we saw a lot of enthusiasm among our members to take up PENAI program and encourage them to be certified. And now we have 3 medical colleges in Salem and 1 in Dharmapuri, which is very close by. So if all our PGs from Salem Dharmapuri Medical College enroll for PENAI, then probably they are going to get certified and they are going to teach the others under them. They may be going to a corporate setup, they may be going to a periphery, they may be going to a medical college, but they are going to standardize the protocol of how we are going to manage preeclampsia. And over the period of years, create SMF fellows who can take charge of obstetric HDU in medical colleges. This is very, very mandated by NMC. So every medical college should have 10 units of high dependency unit, and this has to be almost standardized, that an SMF fellow should be doing this job, and create obstetric high dependency unit in all major hospitals in Salem, and train core members for quality patient care, because we have Dr. Devashri from SKS who is doing a very good job of taking care of high risk pregnancies, but then it has not been streamlined into a particular branch. So we want to have that sort of a thing which is going to happen in Salem, so that our outcome for our patients are going to be good. Work with government medical college, primary, urban and urban health centers to develop a uniform protocol for diagnosing, referral and managing, because sometimes we get reprimanded from the government side for not doing any proper thing. The thing is, they have a different set of protocols. We need to influence them to accept our own protocols from the government side, so that we have a uniform type of treatment. So we won't, the practicing doctors will not have to be cut a sorry face in front of government where they have their own ideas. So we need to influence them to accept our ideas, and whatever has been done or not done, that has to come into place. And support research on PE, because a lot of us are doing, as already told, a lot of us doing a lot of work in government, private, as well as in high-risk pregnancy, but then we are not documenting it. So we are going to support the research on preeclampsia and high-risk pregnancies, and that should be my vision for Salem chapter. Thank you.
Thank you. Thank you very much, Dr. Saravana Kumar. Here I would like to quote Mark Harmon, who once said, "It's a lot easier to do good work when you have good words to share and good people to work with." Thank you very much, Dr. Saravana Kumar. So I would like to conclude by requesting Dr. Anu Joseph to propose the word of thanks.
Thank you everybody for such a wonderful talk on biomarkers and its role in prediction and risk modulations in preeclampsia. This is our second session on the virtual learning series, and it is great to see it has been accepted from the depth and breadth of the country, and not just from the country, from abroad as well. We have had people joining in from even Bangladesh, and of course, Madam from the US. It is great to have had the Salem chapter being inaugurated today. That I would like to thank none other than Dr. Prakash Mehta, sir, for having the vision of this and having us all get in line to do what we can do. To our secretary, Dr. Revati, for having given us the opportunity to have worked for all these things and making us make sure that we are also a part of it. To Dr. Saroj Rana, who has been a guiding light as to how we can go forward with it, how we can have the collaborations done with international bodies like ISHP and have visibility in the international scenario. For all our panelists who made this talk seem so seamless, because they are all experienced in this, in managing pre-eclampsia in the best way possible. Dr. Manisha, Dr. Nagaratnamma, Dr. Srimati, Dr. Sharavana Kumar, everybody was so adept in telling us what they really do. And they were so nice because they know they are doing the right thing already. Hopefully it remains to be such a nice teaching experience and a learning experience throughout our continuing virtual learning series. Next, I would like to extend my thanks to Dr. Smita and Dr. Chaitra, who through their presence made our speak into the screening of preeclampsia and into the making of PENAI, to spread the word that we are doing a great job with PENAI. Dr. Asha and Dr. Veena, to show us that, like Sir said, being such senior practitioners, also still being so happy about have attended the PENAI teaching program, which is going to be a great deal for youngsters to also come in and join in for the PENAI work, because it is really worth it. Every life that we can save with teaching through PENAI project is a great achievement, and it goes a long way through. Dr. Sunita for being the chapter coordinator and trying to make sure that every virtual learning series, now we have one chapter added on, which is a great thing to achieve. Ma'am, I know it takes a lot of work to do that, and thank you for doing it such a nice way. Never the least, the people in the background who we don't see generally on the screens. The SFMI team, the whole of the EC team, and the office and the staff, all the SHIELD members who helped us through this program to be working out nicely. Dr. Prachi, Mr. Kedar, Ms. Chitrakala and Sahiti for supporting us for this event. I hope I have not missed anyone. Dr. Revati, please correct me if I've missed any one of them. Never the least, the office bearers or the office staff of SFMI who have been, I don't know, very persistent that, you know, people join on time, everything is done on time, and they work like clockwork, and it's great to see them work the same way throughout every time. Thank you all for joining in for today's program, and I hope we see all of you next time with many more participants for our next talk, which will be announced soon.
Thank you so much.
Thank you, Dr. Anu. Before we really end, I'll just make one small announcement. This is a conference not from any of the OB societies, but is a conference of the Intensivist Society of India. They're holding an international conference in Bangalore, and we are holding the obstetric critical care as a part of that conference, which is a 4-day conference for intensivists basically. But one session is being held in Jain Hospital in my department. That will be for the obstetric critical care. And I would take this opportunity to invite you all to come for that critical care conference. I'm sure it will be a great learning. And most of the situations where we land up with critical situations would be covered. And at every step, we'll be having a maternal fetal medicine specialist as well as the intensivist coming in together so that our patient gets a complete treatment. So I would like to welcome you all who are attending this program. You could register, you could go to the website of the Intensivist Society of India and join for this program.
Hello, sir. Before we wind off, we have Mr. Kedar Zingade from SHIELD, who has joined in. In fact, he was instrumental in all the discussions along with Dr. Prachi to help for supporting us in the realistic sense to take PENAI across the country through the virtual learning series. So with your permission, I'll call Mr. Kedar to say a few words.
Welcome, Mr. Kedar. Please address the gathering.
Thank you, Professor Mehta and Dr. Revati, and it's a pleasure, joining in. I'm very happy. In fact, I remember having the meeting with Dr. Revati, and it was indeed a wonderful moment for Shield Connect. I would say Shield Connect because we are more of a knowledge sharing virtual platform, which reaches out to the clinicians across not only India but to the world. And when Dr. Revati requested us that, if we could partner of being a knowledge partner, it was a very happy occasion for us at Shield. So thank you so much, Dr. Revati, Professor Mehta. It's a proud moment for us, Shield also, that we are happy to be a partner online and, take this across the initiative across the globe. I knew Dr. Revati since the earlier days where I had done a Professor John Quinlan program. And since those days, we have been together. So it's very nice to see Dr. Revati taking across this initiative and getting across the globe. So I wish the society, PENAI, MFFI, Professor Mehta and Dr. Revati, all success, and we would love to be all the way with you, sir and madam. Thank you so much.
Shield has definitely given us a wonderful visibility to their platform. And I want to inform the delegates that this will be available on the YouTube, which we will share across, through our communications, which you can actually probably use it as teaching and discussion material. Anu, can you please take over?
Yes, so I think we don't have anything else on it.
Until next.
Yes.
Until.
So we have to announce the next date, sir. That's the next job, I think.
6 weeks from now. We will probably come out with a problem.
We'll sit up another midnight and probably think about it.
Yeah, we have always decided that we'll have one program on hypertension every 6 weeks. And of course, in between, as I already said, we are going to have programs on other high-risk pregnancy topics. So everything will be going hand in hand. And I welcome you all to join the SMFFI programs. We have never charged a registration fee for any of these programs because, as I told you, our aim is to reach the remotest of the obstetrician in the country, and we would be very happy to have your participation. Please join us in our next program. Thank you very much.
And we are close to 100 members now, sir. You have to welcome the new members as well.
Oh, yeah. Okay. Now, the Society for Maternal Fetal Medicine, I'm talking about the main society with Bengaluru as its headquarters. We have now 100 members, strong society. Now, please remember that we are talking only of maternal fetal medicine. We are not including gynecology, infertility, menopause, and so on into this society. So 100 member reaching in for a single chapter. I think it's a wonderful moment for us. And I welcome you all to the society. Please feel free. I'm sure Dr. Revati and the team is ever ready to help you out in any way. Maybe your difficult case, maybe your doubts, maybe you would want to take active part in the society proceedings. Everyone is welcome. Ours is an open society, and we would welcome whatever help, whatever way you can help us to reach our goal of improving the women's care, pregnant women's care in the country. We are with you. So please do not hesitate and join us in whatever way, whatever interest you have. It could be just research, and we would be there to help you out. Thank you all very much for being in this program. And I think it's time everybody breaks for lunch. There, I'm right now I'm in Vancouver, so I'm approaching a midnight. But I'm sure all of us are ready for lunch now too.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you, everyone.
Thank you, Dr. Saravana Kumar. Once